All right, so we're going to talk pharmacology. Admittedly, this does not include chapter 23 toxicology, I'm realizing right now. And that is part of today, which means if you're thinking, okay, well, what's going to be on the test? It's going to be chapter 12, 13, and 23.
23?
Yeah.
What's 23?
23 is toxicology.
Oh, okay.
What that means essentially is that we're folding into today's lecture cholinergics, sympathomimetics, and parasympatholytics, these kinds of things. Now, just like every other lecture that we'll find in AEMT, don't confuse yourself by thinking that you sat in a lecture, you're not sure why you don't fully understand it. This stuff takes time and effort for sure. I'll do my best to kind of expedite that and make sure we've got space. Now, we really need to make sure that we understand the different routes of administration, enteral and parenteral. Not only will we have to understand what those statements mean, but why we care about them, which meds are given in which way, and the speeds at which they're absorbed. Like I said, these are the types of questions that we should look for on testing that we just long to see, right? These rote memorization, knock them out of the park kind of stuff. Now, it can also translate to helping us in the field because there's common misconceptions about like intramuscular absorption and IO specifically. People often think that they're much slower than they are, but they're, so it can help us clinically as well, understanding these things. But one of the first things I wanted to talk about, and I wonder, did anybody, going through the homework and learning a little bit about the first pass system, does anybody think they could kind of summarize it for me simply? I wanted to ask a bunch of questions because I'm like, man, everybody filled it out almost perfectly. I wonder if anything was actually learned. Sam?
Goes in the mouth, stomach helps break it down, goes to the small intestines or the intestines, gets into the liver, and the liver sends it to the rest of the body.
Yeah, essentially. So Sam, just to recap, saying if I take a medication by mouth, it goes in our gastric system, goes into the stomach, goes down into the small intestine where all things are absorbed. It's important to note, and that's kind of why I bring it up somewhat. I mean, that was essentially exactly right, Sam, thank you. Is that, as you can see with my artistry here, I've included all the vasculature, and that's what's happening, right? It's crossing out of the gastric system and into the venous blood system in the small intestine, right? And through that, it's going through this, I guess, infamous vein, the portal vein. Remember that? It goes through this portal vein into the liver. The liver chops all those meds up, metabolizes them, and breaks them down. It returns through, what's this here representing? The inferior vena cava, right? IVC. It goes up into the right side of the heart, goes over into the lungs, goes over into the left side of the heart, and then throughout the rest of the body. And what that means is whatever med you put down the grocery hole got beat up by all the acid in the stomach, absorbed through this, and then processed in the liver. And so whatever portion of that exists now is substantially less. Does it become readily obvious why IV meds can be such lower doses than PO meds, right? What happens in this process if my liver is, it's not scleric, what is it? Cirrhotic, is that a thing? Scarred. What happens to this vein? Do you know?
Does it get hypertensive? Is that the portal?
Yeah. If this is getting all knotted up and scarred, if I walk over to this door here, an open, clean liver is a wide open door, but as that passageway starts to fill with scarring, it narrows it like a closed door. And now, essentially, the blood's got to push against this narrowed opening of it. And so it starts to back up. It increases pressure to get it in through there. And because of the pressure, then that portal vein starts to engorge. And so too do these vessels here in the intestines, the stomach, and all the way up into the esophagus, where they're called what? Varices, esophageal varices, right? So not only can liver failure cause all kinds of issues in regards to drinking and processing, medicinally it can be an issue as well. Or put pretty simply, if a medicine is processed in the liver, as most of them are if they're given enteral, liver failure can change the way those are absorbed. Basically, this is what happens. If I've got liver failure and I take that medication, then the liver isn't able to chop up as much as we should have expected it to, which means more of it's floating around in us. And that can be a problem because if I say, oh, I'm going to give 100% dose to a person, their liver is not working very well, but I expected that dose to get chopped up by 50%, but now it's only getting chopped up by 20%. It means I have almost 200% of the medication I wanted to give. Percent, numbers, percent. What it means is if you're in liver failure or if you're geriatric, essentially, right, with decreased liver function just because you got an overdose of birthdays, essentially, it's talking about how we have to adjust some of our doses. Does anybody know why some medications are absorbed or cut in half, whereas others might not be? Molecules, that's a start. Why would we cut a medication in half? Because geriatric and many others not.
Because it would be an equivalent doses if they were fully functioning adult, a good liver.
Oh,
Essentially that.
Liver can't function properly because of, I guess.
Well, just by process of elimination, it might mean that it's just not processed in the liver, you know, in part. So what does it tell us about medications like fentanyl that are cut in half? Well, it must be processed in the liver, right? Not that it's enteral. Now, when we look at these speeds of absorption, I always find that it's easier to remember lists if I can kind of isolate the, what do I want to say? The smallest amount. And so essentially, if you can remember stomach is slow, then all you got to do is remember everything else is fast, right? So if the stomach and PO absorbs slow, then every other form of sublingual is fast. So yeah, enteral. I was thinking sublingual. One question I'm probably not going to ask is, what is sublingual, enteral, or parenteral? It just depends which website you go to, honestly. The reason why some sources include it, including your book, as enteral is because it goes into the mouth, and that's the beginning of the GI tract. Of course, sublingual is not eaten. It's absorbed into the bloodstream, and so therefore arguably is parenteral, you see? But I'm not trying to slice it that thin on you.
So do we need to know like intermediate, rapid, and all that, or just know that PO is slow? Like, or by mouth is slow?
I recommend that you're able to answer a question and associate every single one of these. How I recommend you do that is by isolating the small amount of info. Like in the case of parenteral, if you can remember that anything involving the skin is slow, then everything else is fast, basically. The IM is a moderate absorption, muscle, moderate, right? And so I'm like, okay, it takes me a while to remember the rate, the speed of a lot of these things, but I work backwards off of these easy little tricks, essentially. Stomach is slow, skin is slow. Everything else is fast, except for the muscle, which is moderate, also starting with an M. Summarize for me why a parenteral medication is often quicker and stronger. Tati?
Because it skips like the liver, like the absorption.
Because it skips the liver. That's right. It's skipping that first pass metabolism. It's not even being metabolized until it goes all the way through and then returns to it, right? Very good. It's part of the reason why I've often gotten in debates with people about nasal administrations. They'll often say, hey, your nasal administrations are like double what I had learned. And I'm like, that's because I know that half that crap goes in the stomach anyways. So even though we're teaching largely 2 milligrams by nose, truth is, it ain't gonna bother me if you send down double that, because I know half of that's getting eaten anyways. It's not even being absorbed through the mucosa. Plus, pretty colors. Now, this will come down to the root of the majority of our discussion and probably where the most of our questions fall on receptors. And when we talk about the mechanism of action of our medications, what we mean when we say mechanism of action is, what does the thing do? What does it do it to? And then what happens after it's done the thing? So I always view these like levers. And the reason why that's important is because sometimes if we just view it like a button, then it just kind of has an on, or like a plus state and a none state. But so many of these receptors have a positive and a negative, right? You can instigate a response to the left or to the right. And so as an example, we learned about beta 2 receptors, which are largely and predominantly located where? In the lungs. We've learned essentially that agonism of that would cause what? Agonism of, yeah, that's right, bronchodilation, which means anti-agonism of that would do what? Bronchoconstriction, essentially. Now, this is the sympathetic nervous system that we're referring to, but it's just half of the equation, right? There are other ways to cause or, not elicit, there are other ways to cause or relieve broncho effects. But it's important, like I said, to remember. Now, part of the homework, does anyone remember I said, hey, I asked the question, hey, there are beta 2 receptors in 2 locations, or something like that. List the 2 locations. Say it again. The main 2. It's a bit of a trick question in the sense, because what I had learned is that there are largely 3. Yes, we know that the beta 2 receptors are located on the lungs. You got beta 1 heart, beta 2 lungs, easy. Where else are the beta 2 receptors? Vasculature, which I'd rather not talk about. I found it interesting. Did anybody find it confusing that which ones instigate, which adrenergic receptor sites instigate vasoconstriction?
Alpha 1.
Alpha 1 cause vasoconstriction. What medication do we administer that largely epi? That's right. Do you find it odd at all that if epi is just a broad adrenergic, alpha 1, beta 2, right? Beta 1, beta 2, I should say. Even more. I think there's some listed in the book, and even more, which I don't care about and certainly don't know myself. Do you find it odd at all that a medication that we give to raise blood pressure because of alpha 1 constricting the vessels also gives beta 2, which causes vasodilation? Do you find that ironic at all? No? You okay with it, Tati? Nah, it's fine. Go ahead.
Isn't it because, like, since even though, like, it's being agonist, there's always going to be, like, some small crossover effect? Like, even when you're doing something to the beta 2, it can be a common effect to have tachycardia because it's going over
Yeah.
into the beta 1?
Yeah, and so Tati's essentially saying, like, look, if I'm giving a blanket adrenergic, of course it's going to affect all kinds of things. But my major point is it's a medication that's doing alpha 1 and beta 2 is essentially causing vasoconstriction and vasodilation as listed in the book. The point of that is I think gets down to the core of understanding receptor sites. It gets into the core of understanding that these medications attach themselves in different ways at different strengths to different things. So yes, it will attach to beta 2 receptors causing vasodilation, but that's predominantly in the skeletal muscles, whereas the alpha 1 receptor is on the smooth muscles like your vasculature, and giving epi has a far more profound effect on the vasculature in the peripheral than it does in the skeletal muscles and stuff. So anyway, I found it a bit of irony, but it comes down to what if I said, can somebody summarize it for me if I said, hey, why do we give duonebs? Why do we give albuterol as a bronchodilator and Atrovent as a bronchodilator? Yeah, yeah. More mechanism, like why?
To open their airway.
Will they both cause bronchodilation, Alanis?
They go to the same, but they do different things in the same place.
That's essentially it, Landon.
Because they work on both the para and the sympathetic system.
Yep.
Agonist versus antagonist, is that?
That is also true. I'm impressed. We'll just wait a little bit until somebody says the wrong answer that you will 100% hear from every medic you ever ask. Has anybody ever asked that question to a medic? Why do we give both? I will guarantee that 9 times out of 10 you will get that because albuterol causes bronchodilation and Atrovent dries you up.
Oh, I've heard that.
Oh, well, I know you have. If you've asked it, you've heard it. But again, what I'm getting at here is imagine I give epi, which alpha 1 agonist, right? Yes. What about beta 1 agonist? Yes. Beta 2 agonist? Okay, well, if it's agonizing alpha-1 causing vasoconstriction and agonizing beta-2 causing vasodilation, how does that happen? Well, because it has a much more profound effect in one area than it does in the other, and those two sites control different things in the first place. And so we'll talk about it a little bit with Atrovent to say that sure, it dries you up because really any agonism of muscarinic or parasympathetic effect is going to dry you up. But what we're talking about when we say that is a very mild anticholinergic as far as drying you up goes. Right? We'll talk a little bit more about that later. But again, not only is it important to kind of understand the distinctions, agonism versus antagonism, but also quite simply that you can give a medication that agonizes something very strongly in one way, but not so much in the other. And we'll talk a little bit, I think there's a similarity there between ketorolac and Tylenol, though I suppose neither one of those are going to receptors. Make sure that you're familiar with how medication names can be phrased. Admittedly, the United States pharmacopoeia stuff, I don't see a whole lot of that. One of the biggest distinctions I've ever seen is just the generic name not being capitalized unless it's the beginning of a sentence. That's a pretty easy way through things. These
Generic like the same thing as official?
generic is the same thing as the official. It sometimes
It
is.
says often generic names.
There's an organization I know nothing about called the USP, United States Pharmacopoeia or whatever, and they're making American-specific determinations about these names. I don't know who makes generic names. Maybe it's just colloquial. Maybe we just come up with it. But oftentimes USP is like, oh, so we're all calling it this? Then we're going to call it that USP. That's the official name for it. But rarely, and in fact, the only time I think I've ever heard something given the chemical name, unless you count maybe the cyanokit and nitrous, is aspirin. Does anybody know the chemical name for aspirin? What? Did I hear epi? No? Acetylsalicylic acid. Which, I gotta be honest, I don't even know if that's its chemical name. But I bring it up to say that that's what I would guess for it, and I have 100% seen that on the registry before. They had just simply asked what the medication was, and they listed all these weird names, and it was just aspirin. You had to know that, essentially. So something that always kind of stuck with me. But you'll encounter it a lot because we'll abbreviate it ASA, and that's what the abbreviation is for, is that acetylsalicylic acid. Why it can become a little bit important later, no, I guess it should be important now. Causes tinnitus, acidity, and anyway, we'll get into that another time. Do you remember your question, Alanis?
Do you know the chemical name for nitro?
No idea. And I don't care that you really know the chemical name for anything, except for arguably aspirin, but mostly I just want you to know that they're different and how they look. All right, let's do some drugs.
Yes. What?
So I did my best to kind of condense these things into palatable chunks. If you consider that, at least in my opinion, I'm not a monster, I know full well that you're about to go into a test on Thursday covering your pharmacology, and you just simply haven't had enough time for me to completely drill you on all the drug cards. So I'll know once I get done writing it, but just know that it's written from the perspective of, okay, so I know they don't know all the drugs, so the questions can't be all the drugs stuff. But it'll be highlights for sure. Like, if I had to guess, I'd say going into that, you should know the name of every one of your medications and at least the indication for them, right? Like, it'll be more superficial stuff like, your child has a fever, what should you administer? Not aspirin, but Tylenol, right? These kind of things. So I'll be able to, on the study guide, give you a better idea, but just know that I don't expect you to know the minutia. I don't expect you to have all of your drug cards memorized by the time you take that test. But I do expect, especially considering we're about to launch into practicals, for you to have a general idea, right? I guess I mean scenarios, but practicals are not far off. All right. Before we talk about NSAIDs and these types of things, we kind of have to talk a little bit about prostaglandins. Prostaglandins are a type of chemical messenger. Basically, when we encounter pain, there's a whole list of things I don't remember and don't care about that build prostaglandins. Prostaglandins is kind of the midpoint of this insult to your body. You get stabbed with a nail in the hand, let's say. A bunch of chemical stuff happens, and the result is the creation of a prostaglandin. And that prostaglandin is largely doing two things. Number one, it is sensitizing your nerves to pain so you feel more. And it's also transmitting that signal up to your brain to where prostaglandins are created so that you experience a fever. And so to summarize what I wanted you to know about prostaglandins, I would say this. You should know that they often occur, they occur locally at the site of injury or inflammation. And they also occur in the brain. I believe in the hypothalamus, but definitely in the brain somewhere. That distinction is important to me because I want you to be able to distinguish the difference between NSAIDs and things that aren't quite NSAIDs and how those work. And also I think it kind of helps pave the way for a conversation about fever in the sense of like, if I had a magic wand to stop all fevers, should I do it at all times? And I think it's more complicated than that. That the idea of a prostaglandin being released because I got stabbed by a nail in the fingy, I do want sensitization to pain, right? It tells me to stop walking across this field of glass. This really hurts. Turn back. Or do a cartwheel, I don't know. But it also sensitizes in my brain so that I can communicate that message, and if it's inflammation, it'll start generating a fever response to kind of help my body in that way. Well, NSAIDs essentially stop that process from being made, or from finalizing. If prostaglandins, essentially, if you asked me, hey, what happens when I get stabbed by a nail? I said, well, let's not talk about infection just yet, but let's talk about what happens to the injury site. Well, you're going to experience vasodilation that's going to cause redness and swelling. And so that way fluid can rush to the area, beat up all of the bad things, and then dump it out. And so what's causing this redness and swelling is prostaglandin release. Like I said, it makes you experience more pain. It also then will help communicate that pain signal up your spinal cord and to your brain. But NSAIDs like ibuprofen and ketorolac, NSAIDs specifically stop the production of prostaglandins. Now, why that distinction is important and is, first of all, my wife, she has had migraines her whole life. She took Tylenol for it. She'd take way more than the prescribed dose. We get married. I'm like, yo, I don't know. I take ibuprofen for everything. It's before I knew anything about anything. And she's like, okay. She takes it. Headache goes away, right? She can't now because she's got ulcers, which is part of the discussion we'll have here. But essentially, if we're looking at it like this, because it must have been a prostaglandin issue causing her pain because an NSAID like ibuprofen was stopping it. It's why if I've got shoulder pain with inflammation or swelling, why NSAID specifically will help remediate the problem in a sense. It's reducing the prostaglandin's creation, therefore less swelling, less inflammation. But Tylenol is largely only working in the brain on both the fever portion and the pain perception portion. What that means is if I get a nail in my finger and I've got prostaglandins being created because of injury and I start experiencing swelling and inflammation, Tylenol won't do anything to reduce that, but it will work in my brain to essentially mitigate the response to that. It's like saying this, we talk about ketamine. Ketamine in a certain sense to me is more of a philosophical question. Like ketamine is like, okay, if you don't remember the pain, did you ever feel it? Because that's ketamine, right? Whereas something like acetaminophen might reduce the sensitization of those nerves, and something like fentanyl might bind to the receptor sites. It's largely why we see opiates and acetaminophen combined, because the codeine, the opiate, is binding to receptor sites so that you don't feel the pain, And Tylenol, which doesn't bind to opioid receptor sites, is reducing your sensitivity to that. And so we're kind of attacking it in two ways. I think that came out pretty clear. Are we okay on that? Yeah, all right.
So Tylenol works mostly, like it works in the brain. but
Works in the brain.
Like decrease fever.
And you'll see that that's why I've made a slight change there. I originally just said, prostaglandins, pain reduction prostaglandins, but on the most recent drug cards, for Tylenol in parentheses, it's central nervous system, whereas on ketorolac, for example, I think I used the word globally or widespread. Honestly, if I had more space, I'd say CNS, peripheral, and systemic, but I don't have that space. So now, I still think that essentially that isn't the biggest change in the world, but it helps make the distinction between the two meds. It's all honestly to hammer home the point that Tylenol is primary indication is not pain. What is Tylenol's primary indication? Fever. Whereas ketorolac, a much stronger NSAID, is pain. This year I've stopped teaching IV Tylenol. With us having so many other options, I just felt like when all AEMTs could do was IV Tylenol instead of nitrous oxide, I was like, let's let them do some IV pain meds, man, we gotta get after it. But now that you got ketamine, morphine, and all that stuff, I'm no longer teaching IV Tylenol, but just know that, number one, it can be given IV, and number two, it's the exact same dose, 15 milligrams per kilogram. It is not, however, the same bottle, because the bottle we use for PO is usually a syrup, meaning it has what in it? I felt Michigan.
Yes, sir.
Sugar. Man, spiders changed me. I can remember being in high school, a guy walking by and he was like, what do you listen to? I had my Discman. I said, System of a Down. And he was like, why do guys like you listen to music like that?
I don't get it.
I was like, for the same reason guys like you ask guys like me that question. That's why. Anyways, so I'm not teaching IV Tylenol, but it does exist. And I wouldn't mind in a scenario if you said, well, I'm going to give IV Tylenol in this case, but we won't have it in our bags. But just know that it's a thing.
Question.
So,
So when we have the quiz on the CMO,
mhm.
and it says route, who wants to put IBP?
Ooh, I don't know.
Okay.
What do I have on the card currently? Probably just PO. I think what I'll have to do there is probably just PO is the right answer, and I don't mark you down if you also include IV, because it's technically true. Or this is how it'll have to be. It'll have to be explicit in the thing. It'll say Tylenol syrup.
Gotcha. Okay.
Yeah.
Did you say it's the same dose IV?
Mm-hmm.
If it's interesting because wouldn't it be more potent if it's not? Yeah.
I would think so too.
Okay.
It's possible I'm misremembering it, but I don't think so. But yeah, I would agree as well, especially since Tylenol is largely processed in the liver, not the stomach, So yeah, I'm not really sure, buddy. I will say this, there's a lot of nuance to these meds, different things being metabolized in different ways. A lot of the answer to the question of why, if they're both this thing, does it do this here? And I'm like, buddy, that is deep chemistry for me. But that's usually the answer, like one of the things is like why some of the meds get doubled when they're intramuscular, but others don't. It's just a flat dose in either case. Oh boy. There's something we don't want on my Discord or WebEx. Let's get that out of there. My buddy Steve likes to send me pictures. There we go. Well, I think we're safe now. So, understand that Tylenol is an anti-pyrez, close, baby. Fever reduction, prostaglandin inhibition in the central nervous system. Make sure you understand what fevers are. See, this is the kind of questions I'll be probably asking, like checking, are you reading your drug cards? Do you know what a fever is? I expect you to have full understanding of vital signs and fundamental knowledge of these cards. Now, it says here specifically, rarely given to adults pre-hospital. Why am I giving it to children pre-hospital, but I'm less inclined to give it to adults? Tati?
To try to reduce like the febrile seizures.
Boom! Because febrile seizures are more common with children and largely non-existent with adults. So realistically, The reason we give Tylenol is to prevent febrile seizures. That's the #1 reason we're giving it at all, which means if you're not in danger of that, you probably don't need to give it. The reason I stress that is that if a child has a fever, it's probably not too crazy to let them ride it out unless it's causing a problem. Now, you're not wrong if you get a kid that has a fever and you're just like, boom, draw up PO Tylenol and go ahead and administer it. Like, that's not wrong. That's fine. Absolutely. But it would be my hope that we can kind of get to a place where we are monitoring that situation, monitoring our patient, taking in how they're doing and adjusting, and then kind of trying to decide whether or not we're at any risk for febrile seizure.
Is that kind of a thing too, where like, if that would be the only reason you'd be getting a line, you might withhold that kind of thing? You know what I mean? Like,
Well, we wouldn't traditionally be giving it IV, but that is philosophically, I think, similarly. Though I'll say this again, for the first year or 2 of your career, light people up, man. Do IVs like crazy. Every patient gets an IV. Absolutely. It's not that bad. It's not that dangerous. It doesn't hurt as much as I think many people will say. And darn it all, we need the experience, right? I don't want you coming to my house when my kid has cut himself on glass and you're shaking hands because it's the first time you've ever done one. I'm like, no. You had 9 other patients today you could have practiced on, right?
So my question is, so we give him Tylenol for fever.
Giving Tylenol for fever, yeah.
Yeah. But you reduce fever, but it's not, fever is caused by something, right?
Yes, ma'am. Fever is caused by something.
So you still want to do that? It's like,
Well, and that's ultimately my point, is that look, if you want a simple answer, kid has fever, give Tylenol, I'm into that. It's not crazy. What I would prefer is if you could kind of look at it and say, well, look, he's only at 38 degrees Celsius, or he's only at 100.5, and I've got him with a sheet, so even when I take him out into the cold air, he's not going to get hit with a big blast of cold. I'll set the thermostat there at the right temperature so there's no major changes. I think that is a way better clinical answer, because because that means you know that the fever is intentional, that the fever might be helping. However, if you're like, whatever, dude, if I get fever, I'm giving Tylenol, I'm like, that's all right. I don't think that's crazy. What's also important to note is the toxic dosing. Now, there's a lot of different literature out there that will talk about it. I want to say that it's pretty widespread as far as remembering what the toxic dose is. It's something like, I want to say 25 grams of it guarantees your liver stops. Guarantees your liver dies. Now, Tylenol, you can get your stomach pumped, and they also have an antidote they can give, so it's a pretty simply correctable thing. Where I usually encounter this is young blonde white girls who want to take it essentially to kill themselves. Now, all people of all cultures, creeds, and whatnot can definitely take Tylenol to kill themselves, but that's the demographic I've anecdotally seen time and time again, and I don't know why. I don't know if they're more likely to attempt. I don't know if they think that Tylenol is not so dangerous, or if they're taking it because they know exactly how dangerous it is. I don't really know. But what do I say? If you want somebody to go to the hospital, right? You don't want them to refuse. What do I tell you? Alex?
Tell them how bad their life will be if they don't do it.
Yeah, that's kind of what I'm getting at. And the kitschy way of saying it would be like, if you want to get people to go to the hospital, you don't tell them that they need to go because they're going to die. You tell them they need to go because they're going to live in pain or deformed or disabled for the rest of their life. That's how you get people to go.
I remember that from my B class.
Yeah?
And I was like,
Sounds like a smart teacher.
Funny. And one day I get a patient that's like, dude, you have to go. He's like, you need to die if you don't do something about it.
And he responded, I know.
No, he told me, don't try me with a good trip. I'm like, what? What are you talking about?
Threaten me with a good trip? What, his death?
Yeah, I'm
Yeah.
dying. I'm like, oh, okay, funeral was like, cool.
Yeah, he often is. Yeah, Houdini said, presumably on his deathbed, and now the greatest mystery, which I think is fascinating. Yeah, and so the summary of that, if you're not quite following along, is the idea that, look, most people who are suicidal know they're going to die if they did whatever they did. That's why they did it. And so the conversation I would have is I would walk up to each one of these patients and I'd say, hey, look, sweetie, I know, did you take this much meds because you want to feel better or feel worse? Because some people took a lot of pain meds because they want to feel better, not worse. They just don't realize it's going to kill them. So if they say, well, I took that many meds because I want to feel worse, I want to die, then I don't say, well, you took it because you want to die, that might kill you. They're like, yeah, I know, right? I tell them, look, I always say, there are two conversations I want to have with you today. One of them is how I don't think you should kill yourself, but more importantly is how you shouldn't kill yourself this way. This is not fun. Google insulin. That ain't no big deal. But Tylenol is like somebody twisting a rusty knife into your liver until you beg for death. That is not how you want to do it. And so usually I have never had a person, and I've said it many times, I've never had a person refuse to go to the hospital after that line. They're like, oh, that sounds miserable. I'm like, whatever situation you have going on in your life right now, imagine now being at the beck and call of some other human, like because you live in liver or some type of major liver, like, no, dude, you do not want that. So just be aware of those things for sure. Like I said, refusals, man. We're in the business of transport, and if somebody pounded them, now admittedly, it's gotta be a lot. If we were to look it up, essentially what the adult Tylenol dose is, it's a pretty gnarly amount. Like usually they're like, yeah, I took like a handful of pills, and I'm like, yikes, that's crazy. But in my mind, I'm thinking like, you need 2 bottles of that stuff? So it's just like calories though. If you're drinking it, it'll go down way, way faster. That's where it gets a little spooky. But in any case, make sure that you know essentially that it's 150 milligrams per kilogram. Yep.
Aspirin can reduce pain at the site of injury by stopping prostaglandins.
Yep, because it's an NSAID.
Why do we only give it for chest pain?
Let me ask you an important question. If aspirin can stop pain at the site of injury because it interferes with prostaglandins, why do we only give it for chest pain? So we call Socratic method. I mean, what's going on over here?
You have any more copies of the new A&P cards?
Yeah, sorry, I'm trying to find the drug cards.
Okay.
Maybe there's a better way to stop pain?
Sorry.
Thank you.
No, that's fine. No worries. Maybe there's a better way to stop pain. That's not a bad guess. It's not the only thing it does. It's way better at something else. What is it really good at? Antiplatelet. Fentanyl does nothing for platelets. You know what it is really good at? Getting high. Yeah. Yes, it does. It literally goes to different centers in your brain to change how you perceive. It's wild what it does in there.
Something funny about that. It doesn't say a contraindication. They will be like,
Talking about fentanyl?
like psychosis and stuff, and it's like you don't want to give.
That is.
For that, because the pain.
That's a strong point.
It's amazing. I saw it in a patient. There was schizophrenic.
Yeah.
If you give ketamine, it will make them crazier.
Yeah, I mean, I don't think so. I can appreciate there's some sensitivity there. Honestly, what I'm about to say comes largely not from my professional career, but my personal career and experience with a lot of different drugs, which is to say that I would largely put up, and honestly, I think conversations like this is important. The longer I teach this, the more I'm like, wow, I think I grew up pretty rough. Because it's funny how different, you need to know as AEMTs largely what some of these street drugs that are not in your scope are doing to people and how to interpret that and base it. So generally speaking, I kind of put some of the fun drugs up on a list, and we'll start with Molly, MDMA, all the way on one side. And as a buddy of mine said once, oops, I think I took twice as much as I needed to. I said, don't worry, dude. No one has a bad time on Molly. It's not possible. Right? Most drugs are Faustian bargains. Most drugs, even alcohol, is taking tomorrow's happiness and putting it in today. So today is better and tomorrow is slightly worse than it would be. And to a greater, lesser extent, that's what these drugs are. And Molly takes a week's worth of fun and crams it into a day, where the grass has never been so green, everything is really, really soft, and there's just a hum of beauty flowing throughout your body. And then many people struggle for like a week with depression afterwards because it squeezed all the fun out of it, right? In fact, many people, I had buddies that would go to raves, they would do Molly quarterly, because of its effects on the body and how much it drains you. Okay, so that's way over on one side. That's an emotive, empathetic experience, right? Just to the other side of that would be like psilocybin, like in mushrooms, which are somewhat empathetic near Molly, but they're also getting a little closer to the dissociative side. So mushrooms, essentially, you're starting to be like, oh wow, like everything's soft and everything's fun and I really like you guys or whatever. What the hell was that? Like, you know, it plays on your periphery. You ever had that experience essentially where you're just like, whoa, I thought somebody was walking up next to me? I mean, largely what that is your brain is constantly filling in information based on limited input, right? And mushrooms getting farther away from the empathizing side and closer to essentially the dissociative side, they are starting to turn off your ability to stop that from happening. And so you look over and it's not just like, yeah, I mean, I guess I could make a face out of that. No, you see a face. Your brain fills in the information, right? And so then as we move farther away from Molly, we move farther into the dissociative side, essentially, and the psychedelic side, we move into acid. And acid is more math if mushrooms are more art, right? And essentially, I'm moving farther and farther away from the feel-good. I always described acid as just sideways, right? It's very analytical, very math in a lot of cases. You can tell after your experience with both, you can look at art and be like, oh, okay, that's kind of acidy and this one's kind of mushroomy, because you're getting farther away from that side of things. I don't know why it's cracking people up so much, but it's my experience at least. And so again, we move from mushrooms, much of the less silly, fluffy, and much more into acid, which is more analytical and more dissociative, right? And then as we move farther to the left is ketamine, which is its farthest edge of recreational disassociatives, in my opinion. You could slot DMT in there, but that's another day's worth of talking. And so what we have there, in my opinion, is Molly on the right, which is just fluffy pastel, whee! And then you have ketamine over here that is just a snipped psychological wire, essentially. It's very out of body, it's much less bright colors, and much more just, I am a vehicle. Something is transporting me, right?
We get ketamine though.
Yeah, baby.
But that's what I'm talking about. There's like,
Oh, but this is all getting to the point, is that I don't know any science or anecdotal evidence of anybody getting opiates and slipping off the planet. Like, but I have had friends who did ketamine once and never came back. Never came back.
What do you mean?
They probably, I would suspect, had a history of psychosis.
that's one.
And I know they were weird and they probably had it in the family, but it's the only drug I personally have ever seen where somebody was like, you know, because mostly it's a scare tactic. You do a drug and your whole life will get destroyed. I'm like, there are some that are very slippery slopes, heroin, cocaine and the like, sure. But most of it, not that way. But I've seen twice where somebody did ketamine once, it snipped something and they never came back. They were always different after that and odd, like not be able to hold down a job. So the point is that I do think that you are so right. I don't mention it anywhere in here about the dangers of somebody having a history of psychosis and administering mind-altering meds.
It's not actually contraindication.
It's not, but you are correct. I have had patients who suffer from opiate addiction say, I'm in a lot of pain, but please don't give me an opiate. So we'll give them Toradol instead. They don't want to get back into it. So I'm glad you brought it up. It exists nowhere in this lecture. But I will say that if I've got somebody with psychosis, I mean, I'm probably choosing a benzo over ketamine because I'm like, I've personally seen people.
Is that like a question we should ask before we give ketamine?
I think the best way to summarize this stuff is let's not convolute what will definitely take time in your job to learn with the fact that I think Alana succinctly said, if it's not listed as a contraindication, don't worry too much about it. But absolutely, personally, if I had somebody struggling with psychosis, I would go with other options for sedation as a medic than ketamine. So, But again, it's not a contraindication, and your protocols won't state that, so do whatever you want, do what your doctor says. I got a buddy of mine who is actively candy flipping cocaine and ketamine right now. Whew. That dude is definitely never coming back, you know? I mean, I went over to their house the other day. They were sober, according to them, for 3 days, man. They're just culty looking, you know? Just like, what are you eating? I'm like, what do you mean what am I eating? You know, they're like, do you ever think about what we eat? I'm like, you high right now? Like, what in the world? We'll talk about ketamine in a bit here. It's just, it falls down into one of those medications that I just like, look, I think there's a couple people should try. It ain't that one. In any event, let's talk about Toradol, a medication that you can do and can give. This is kind of super ibuprofen. It's IV ibuprofen. It's super good at stopping prostaglandins. Now, should we suspect that if this is an NSAID and very good at reduction of prostaglandin, that it also reduces fever? It would have to, right? And it definitely does. The question would become, well, then why aren't we giving this med instead of Tylenol? Say it again. It definitely does other things, and it's very strong. You wouldn't be wrong. No, I guess technically you would. I don't have anywhere listed on there that is for fever. I don't think you're crazy to give it to somebody for fever, but maybe I should. The reason for that is that does anybody know if you take ibuprofen for extended periods, what happens to your stomach? You start to get ulcers. Stomach requires prostaglandins in a way that I definitely know, and I'm just not telling you because we don't have the time, not because I have no idea. But it uses prostaglandins to help increase and supply the lining of your stomach. Well, if you take an anti-prostaglandin thing, it's going to decrease the lining of your stomachs, and so then the acid in there is going to eat it away. Hence, NSAID outside of H. pylori is one of the major contributors to stomach ulcers. That and stress, I suppose. Well, part of the reason why we're not giving this for fever is that Tylenol does that just fine, and this does that big time and a bunch of other things. Like Tylenol is hyper-specific in the brain and in the temperature sensories, right, for the prostaglandins there, but general NSAIDs work globally, systemically, right, and peripherally. Essentially, this is working big time in your stomach. And I can't remember, but it's like, in the ICU, it's like an 8-day limit or something. Like they have a cutoff where you cannot take it ketorolac that many days in a row. 5, awesome. Yeah, the point is it's super strong, which means that if I can get a med to do the other parts of it without all of those things, then I'm gonna. And that's kind of what we're talking about with aspirin as well, because aspirin is an NSAID. So will it reduce fever? Yeah, and when people are allergic to Tylenol, guess what they get? Aspirin for fever, usually. But the reason I'm not giving it all the time is because that's not all aspirin does. And what we don't need is to decrease platelet aggregation on a person that just has a fever. And so a lot of these meds are about, okay, what do it do? Where do it do it? And then what do it happen? Yeah. Now, what's interesting here, well, all of it's interesting. I looked this up here, essentially why we double the IM dose. The simplest answer is because IM absorption is slower and it's processed differently. Truth be told, I don't remember. It has something to do with the molecules and the way they move and blah, 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 but I don't care. I don't think you need to either. But you do need to know essentially that it's doubled. The question I had is why we don't essentially double the IM dose if we're doubling the adult dose, and it took me down a path of, chemicals and stuff I don't remember. But a lot of this stuff, if I'm being honest, I think it just comes down to the philosophy of, well, you can be studying the roots or gathering the fruit. It depends what you want to get in on, right? What I can definitely tell you is that's what we're going to be dosing. Now, I keep making this distinction, right? Even on the drug card quizzes, allergic to this med or NSAIDs. It's one of the only unique ones there. And the reason is because I just so seldom heard people say it in the field. They'd just be, are you allergic to aspirin? The guy would say no. And I'm like, okay, he probably doesn't know that, but he might be allergic to NSAIDs. If he's told he's allergic to ibuprofen, then it might be allergic to NSAIDs, and it's something that we need to make a point of. Moreover, I remember seeing a testing question that said which of these is not an NSAID, and Tylenol was the answer. So it's a double whammy as far as education goes. And I love whammies, especially when they're doubled.
What if they don't know what NSAID is or
They might not. You just do what you can.
For like
You get a blackboard and you start describing to them what a prostaglandin does. That's what I would do.
for Tylenol, it says it's a non-NSAID.
Yeah. Non-steroidal. Yeah.
What?
It's steroidal.
I feel like I'm getting.
It's steroidal, yeah.
Yeah. Is it actually?
I don't think it's steroidal, and I don't know. I think that's how it's described.
Okay.
An ATM machine. Now, one of the things that this is a direct contraindication, we used to have pregnancy categories, and it was really convenient in education because I would teach you that, X means no go, don't give it to people who are pregnant because it'll make their babies have claws and all this different stuff. We don't have those pregnancy categories anymore. Now they come with what I would describe as very unhelpful paragraphs explaining, but the summary of it is this. We largely classify these medications on some varying double integrated scale. Like, did we test anybody on it? And if we did it show any results? And there are several categories there because we do animals as well. Meaning, the FDA says, well, I approve this. Well, have you tested it at all? Yes, I've tested it. On what? Animals. Did it do anything? No. Then it gets this category. Yes, I tested it on animals and it did do something. Okay. But I haven't yet tested it on humans, which means we put it somewhere in the middle and kind of so forth. And so there are not many pre-hospital drugs, especially available to an AEMT, that we have to worry about have to worry about being a danger. I list them specifically. What's PDA? Medically. Don't show me with your neighbor or whatever. If I said to you, both of my boys were born with holes in their heart, how would you react?
Just arteriosis.
Yeah, me too. Everybody is, right? We are largely, every one of us are born with a hole here between our atria and a hole here between our major great vessels. That's normal. Why is that normal?
Because they have to bypass it with the cord. The umbilical cord makes it.
Kinda.
They don't need to oxygenate their own blood.
That is true.
They're not breathing.
Yeah, they're not using lungs. So we just bypass the lung part, right? Now, we've learned essentially that if you administer ketorolac to women who are in third trimester pregnancy, there is a strong uptick in this ductus arteriosus not closing and staying patent ductal arteriosus. So it's worth noted. Oh, is that where you got the 5 days? I wrote it down. You're so smart, Landon. So this goes back to a conversation I think that we basically already had. We have to ask ourselves, right, Rose, if I have a patient and their heart rate is 110, is that good or bad?
It depends on the person.
Oh, get after it. Depends. It depends on if it's a pediatric or not. Maybe it's normal. It depends on their age. It depends on their condition. Whether or not they're bleeding to death, 110 heart rate is suddenly amazing. Right? Potentially. Because it's compensation. And so much the same, fevers is a question of is it the cause or the cure as well. Now, I will note that we teach shock treatment largely as oxygen, supine, and blanket. You'll find yourselves trying to treat patients in septic shock, and you'll be like, whoa, no blanket, because septic shock. Well, if it's a kid, that's particularly dangerous, right? Because they're susceptible to febrile shock, seizures. But also, we still want to help them regulate their heat as their hypothalamus is going way out of whack as prostaglandins flood the area and their fever shoots through the roof. I mean, let me put it to you like this. You ever had a fever? Did you feel super cold? I mean, at times super hot, at times super cold. I mean, if I said, hey, I want you to picture you've got a flu and you're in bed at night, you're bundled up and shaking. I mean, you know what I mean? So it never ceased to amaze. I'd come in with a sheet over a patient, not a blanket, but a sheet over a patient, and the nurse would be like, well, what are you doing? Get that off of them. And I'm like, dude.
Yeah, there's some people that make you take cold showers.
Oh, yeah?
My mom used to.
Hispanic culture for sure. Yeah. hang up pictures of Jesus in the tub and take a cold shower. Oh, I remember.
Do we cover them with a blanket or we don't? I'm sorry. So no.
Say it again?
No.
Why wouldn't I cover somebody with a blanket that had a fever?
Well, you said they're shivering, so that's not that.
Yeah, maybe cover them with a sheet to help them kind of regulate it, but I don't want to get them overheated.
Okay.
So that's what, put very simply here, just know that a fever can help. If you looked at it pretty simply and said, oh, okay, you're in the middle of a scenario and you're like, oh, my kid's got a temperature of 101.2, I'm giving Tylenol. Wonderful, we need the med practice anyways. But again, I would be okay with you kind of gauging it and saying, all right, well, look, he seems to be completely alert and oriented. His fever's not that high. I'm going to cover him with a sheet, and we're going to be real careful with him. If it starts to go out of whack, then I'll go for the Tylenol. I'll be like, love it.
Do they carry the liquid syrup Tylenol in the trunk?
Who? Oh, most people do.
Okay.
Mm-hmm.
You said maybe IV, but if you don't have the liquid.
I've never seen it.
Okay.
Do you work in EMS? Yeah. Where are you at? Oh, well, that's right. We're all Metro here, right? It wouldn't surprise me at all if somebody was like, oh, I'm at AMR and we started carrying it. It's hard for me to track anymore.
Okay. I missed that part. Did you just say put a sheet on?
Yeah.
Why?
To help them thermal regulate.
Is it high?
Sure.
Is their temperature high?
Yeah, because I don't think that a sheet is essentially going to heat them up, and we can prove it by putting you in a cold environment and giving you only a sheet, but it can help kind of neutralize the shift, and I think that's completely appropriate. Say it again.
What do you mean?
I mean, a sheet's okay. That's what I mean.
Yeah.
Yeah. Okay. If your concern is that what if I put a sheet on them and it drives their fever up higher?
Sorry.
I don't think it's gonna, but if you're worried it will, give them Tylenol. But in any event, I'm like, we do two things essentially. Our body naturally tells us to do two things when we're at home, when we've got the flu, which is to drink lots of water and get covered with blankets because our hypothalamus is so far out of whack essentially that we can't thermal regulate very well. And so at home, like I said, it always cracked me up with the nurses essentially, where I'd come in and the guy would be drinking his own water while I'm running an IV, and they'd be like, whoa, nothing by mouth, and he shouldn't have a sheet on him. I'm like, I bet if you get his lung virus, you're gonna go home, drink a ton by mouth, and then cover up with a sheet. I'm like, so I don't think it causes an issue, and they can make him very uncomfortable. And shivering, arguably, is gonna cause a more profound adrenergic response. Receptor sites is the topic of today. Most of what you need is memorization, but receptor sites is why you need me. That and for eye candy. Now, these receptor sites are essentially these little grabby hands waiting for a specifically shaped chemical messenger. There's a lot of different kinds. They are in a lot of different locations. For example, I don't have opiate receptors on my hair, so far as I know. So if you give me heroin, it won't attach to my hair. It'll flow right on by. But it will attach to the opiate receptors, and those are located in different spots. If you were to give me, I can't believe we blew right by the beta-2 discussion about stabilizing mast cells and basophils, but we'll get to it.
We're going to hear that a lot.
Yeah. So the receptor sites, their location matters. Where that little lever is when it gets pulled and what it does matters. So if I've got beta-2 receptor sites on my lungs, but I don't have them on my veins, let's say, that means when I give albuterol, the beta-2 medication flows through my veins without ever getting stopped or attached, flows past the vasculature of my lungs, finds the receptor site there, and then attaches and elicits a response. Are you with me so far? Is that learning or confusion? It's hard to...
I was learning because I realized why we now give albuterol SBN, so that way it only attaches to the bronchioles rather than getting all caught in the vasculature.
Yeah, so I don't think it's only why. Like, I think that if we could somehow find a stabilized molecule of albuterol that we could inject IV, it's just that it won't do anything until it gets there, and we can pretty easily, unlike other parts of my body, just directly apply it to it. Yeah. Now, what's worth noting essentially is that agonists are medications that are activating receptor sites, and antagonists are ones that are preventing activation of that site. Now, some antagonists bind to the site first and prevent things from binding to it, and some of them just block them from binding in general. But what's most important is that you can make the distinction between agonizing and I remember it like the antagonist in a story, the bad guy, which, if you're making any conclusion here about why I consider the good guy in the story the opiate molecule, that's perhaps for anyone to decide. Mostly it's just because that's how language works, anti-agonist, the preventative part. Let's talk specifically about what's pronounced mu receptors. That's that little U, which I just learned in statistics, by the way.
You actually pay attention in statistics?
You stupid idiot. Of course not. Okay, I
It's just like
barely
stuff,
passed
like-
algebra. You are talking to a guy who in his free time has so many charts of the statistics of veritable dice rolls and
crazy, like,
oh dude, okay,
I cannot teach.
did I ever tell you about the girl in California I dated named Emily? She brushed her teeth so much their teeth fall out.
Oh, yeah.
Right? Okay, I know, she's a beautiful girl, but she got told essentially that she brushed her teeth so much that her teeth would fall out if she continued to do it. Her dad had OCD, and so she was a little ticky, right? I'm trying to wonder why we got along. But she, in 20 years or whatever of being alive, couldn't find a way to stop herself from brushing the teeth, so what did she do?
Find that brush.
Softer toothbrush. You're all deeply immersed in my relationship history, that's right. She made the environment suit her situation, right? And so I guess all I mean to say is that I've been trying to find a way to make myself less picky and ticky and just cycling, spinning neuro, and I don't know how to turn that off. I just started pointing it at stuff. Pointed at EMS, suddenly I can help people like crazy because I spit it up all night writing little charts and schemes, and I got a heat map of your grades. You want to see a heat map? We'll do it another day. Dude, it is wild. Anyways, mu receptors. So statistics, honestly, for me, is fun. The guy was like, well, if I rolled 2 dice and I'm looking for a 1 or 2, I'm like, I made those charts for fun in my spare time. Thankfully, I'm already married, or else I'd be a little nervous. All right. My wife, dude, she just did Red Man. Do you know Red Man, maybe? It's kind of, you have to like run through the obstacle course, and then at the end is a man in red foam, and he whoops your butt. Mm-hmm. Yeah. Well, the idea is you're exhausted, and now a suspect is attacking you. What do you do? Yeah. I should have been a cop, man. She's like, I don't think you would have been real happy watching that guy hit me. And I was like, knowing full well that you're going to be out in the world in bulletproof vest, I'd have kicked you when you were down. Absolutely, baby. Made of iron, that girl. Okay, mu receptors. Just like Lauren was saying. Thanks for getting us on track here. Opiate receptors. The point is this, is we have opiate receptors and our nerves in the spinal cord, and agonizing these things, right? An opiate binds to this site, and it prevents the response. Don't get too distracted by a lot of the sodium and potassium stuff here. I don't need you to know that. Mostly I need you to know that opiates are binding to opiate receptor sites and preventing your ability to feel that pain. Now, it's not the only place that we have opiate receptors. We also have them in the brain. We've got them on our accumbens and our amygdala, where we're both experiencing the pain and we're accessing memories and stuff about how we feel about pain. But also we have them on our brainstem. And so as I essentially administer fentanyl to somebody, it flows throughout their body, binding thankfully to the nerves in the area that it was hurt, desensitizing them. It binds to the opiate receptors in the brain, changing the way they perceive and feel about pain. But unfortunately, it binds to their brainstem. And if you're at home doing too much of it, that's what kills you, is it binds here and it prevents something from happening. I should say this not to confuse agonism language. And this is kind of what I mean about the lever situation. In this case, an opiate is binding to the lever and causing an activation that is then preventing the pain. But it's not just taking away pain. let's talk about fentanyl.
Can we give that in Georgia or?
You can give like a third of the things I'm going to teach you about today in Georgia. Georgia is shockingly conservative, let's say. The irony is something like 60% of all AEMTs in the nation are in Southeast America. It's a beautiful contradiction. In any event, you're taking a national test, so listen up, mutants. Owie. So, analgesic, essentially, opioid agonist. Yes, we're reducing pain, much like the other things we mentioned, but this one works on our central nervous system specifically. We give it 1 microgram per kilogram. We give it half dosing for over 65. Why is that? Yeah, something about liver, which honestly is good enough. Actually, I don't even care that you know that. I just think it's cool. It clears in the liver. Put pretty simply, fentanyl is fat. Would somebody Google for me whether or not Versed is fat soluble?
Versed is some, bro. When I had to go for that, when I had
Got you some forget me juice?
Bro. I was like, she was like, go ahead and sharpen it. I was like, strap me down. No, I was gonna have surgery, so whatever.
Versed, fat soluble?
Both water and fat soluble.
Okay. There's a host of things that you can give intranasally pretty easily because they're fat soluble. That's a different conversation. I just couldn't remember about Versed. In any event, we're going to have our dosing for adults. The irony of this is I think that's so stupid. Geriatrics. You know, I called up meds, orders for med. I think when I last worked at Metro, we had to get orders for fentanyl, I think. I can remember calling and asking a doctor for meds for fentanyl and him giving me just a straight dose. You know, he's like, yeah, go ahead and give like 125 or whatever, 125 mics. And I was like, do you want me to have that dose, doc? And he was like, nope. And I was like, hell yeah, right? So we sent that geriatric for a ride and I came in and I said, hey, how come no having of the dose? And he was like, because it doesn't work very well if you cut it in half. And I was like, see, that's my experience as well. Now, it will never be the right answer on a test. You have to know to half the dose at 65 because that's essentially the benchmark. Anecdotally, that sucks. Turns out when you cut a drug in half, it doesn't work very well. That's my experience.
Yeah, so if the problem is like the liver has a decreased ability to process it.
Yeah.
I would think that you would want to give more.
So there's two things at play. When the liver can't do its job, you end up with more in your system, which can be toxic. And so that's not good for them. Secondly, it's not just like processing it, it's turning it into different molecules. And so it's possible, though I don't know, that the fentanyl we give isn't the immediate and usable molecule, that it maybe has to go through the liver where it gets combined with blah, 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 and becomes such and such molecule, and then that's being used. So there's a lot more at play there.
I thought it was bypassing the liver if it's through IV.
Yeah, I think that in this case, and it definitely does because it's a parenteral route, I think that it has to do with buildup more than anything. That it's not that it's going to be just as effective. The problem is it will be more in the system because it's being processed less. I'll never forget, I had a patient that was getting, we went to her house, German woman, and my wife is one of the best humans I know. Just good. But I would not describe her as kind. But I think good is more important, you know? She's not very tactful. When I say voted for Bernie Sanders, buddy, I mean voted for Bernie Sanders. And so, I went over to this woman's house, this German woman, she tried to kill herself. She had this steel 32 revolver sitting there, or 36 revolver sitting there on the table. It was awesome. Made a beautiful sound when you spun it. She was so cool. We ended up talking about art and music. She was awesome, to the point where I gave her my number, gave her a wink. No, I just said, hey, when you're out of the hospital, you call me. I'd love to introduce you to my wife. Like, you're so smart like her or whatever. Like a week later, she calls me up and I'm like, hey, how are you doing? Are you still feeling down and stuff? And she's like, not at all. It turns out the med she was taking, some brain med, since her husband had passed, essentially, had built up in her system over time because her liver wasn't functioning at the capability it should. So it just kept building and building and building, and it made her completely cracked and spooked. And so, at least according to her, she's like, no, I'd never been depressed. The med was twisting me all up because my liver wasn't processing it effectively. The med was still effective because the dose wasn't getting chopped down. The problem is that it was polluting the water. Anyways, my wife sits down with her and they start talking politics. And when this German, when I tell you a dyed-in-the-wool Trumpster buddy, whew, my wife is just like, that is so stupid. Why would you ever think that? I'm like, she tried to kill herself a week ago. Easy. Psychopath. I still have the pine candle she gave me. I was like, baby, needs some tact, girl. Yeah.
So it's a top dose for geriatrics, and on a slide, the next one, it's fast acting and shorter lasting. At what time do you give your second dose, and would that at that point be considered a full dosage?
We are essentially not teaching repeat dosing.
All right, so we're not going to give another dose for that one then.
Yeah. And I think that's probably the best, safest way through it. Most of my career, I didn't do weight-based dosing. I gave 50, saw how you felt, gave 50 more on the way to the hospital, and that was life. We're going to teach weight-based dosing, and we're not going to talk essentially about repeat dosing and run into separate issues. I don't think that it's crazy, but quite frankly, I just never thought about it. Especially now that, since you have a reversal agent for this, it's probably completely okay to teach, hey, every 5 minutes or so, go ahead and give it. But I haven't thought about it enough to kind of gauge it. So I would say, let's just do single doses. Let's just do single doses. The irony of all this stuff is it's so hard. This reminds me, if you've ever been a girl, and went through a OBGYN lecture or whatnot, you're like, sure, some of that stuff is complete nonsense. My body doesn't feel that way, look that way, or I'm like, okay, we're kind of giving a general message in a lot of these ways. We're taking all of humanity and condensing it into one topic. And part of that is that, like, I'll tell you that this is faster acting and shorter lasting and that morphine, because that's what the book says or whatever. I have had wildly different experiences with this. I mean, I can remember running 2 calls back to back in Michigan. Ice is all over the ground. This big, what do you call him? Jacked. He could be jacked. He was like a master sergeant. He was just, and he slipped and he hit his head on the ice. And so I gave him like 50 of fentanyl, and the guy lost his mind. I mean, I took him into the hospital and he was like grabbing people as they went by. He's like, this is a great American hero. And I'm like, dude, quiet down. I just gave you a bump. Oh my goodness. And the girl after him was a 20-some-year-old athletic trainer who had fractured her arm, and I gave 50 of fentanyl to, and she was like, sorry, it didn't touch. I mean, stone cold, you know? She's like, sorry, I didn't touch him. I'm like, that's all right, I'll give you 50 more. Stone cold, didn't touch her. I'm like, okay, give her like 2 milligrams of morphine. And I'm like, I think bodies just respond differently to this stuff. So one thing I'm not saying is, hey, if give fentanyl a bunch of times, what I'm saying is if they start to develop pain again, maybe now we were running something else with it. Yeah.
In situations like that, where you might need to give multiple different medications, do we need to worry about like a dangerous synergy between the two?
There isn't. It wasn't until we added Cyanokit that we really had any meds that interacted inappropriately. Okay. So sodium bicarb is a big one for that, and calcium gluconate, and we don't do either one of them. So essentially, no. Now, make sure that you know that it can cause hypoventilation and that you're well aware of the reversal agent for that, which is what? Narcan. Bigum Narcan. Make sure you know that pain patches are a thing. Right?
Is it safe to put everybody that we put or give fentanyl on for end-tidal? So anytime we give
Yeah, I think it's Grady even requires it. Like Grady is like, if you ever give an opiate, you put them on end-tidal. I always say this, like,
I don't think it's crazy.
it's not crazy. In teaching world, I think you should have all humans on end-tidal. The truth is I wash mine and they put them on plastic mannequins, so I have infinite number. But in practice, no, the only reason I put somebody on end-tidal is if I was concerned they were having respiratory problems. And if I gave you fentanyl and you weren't having a respiratory problem, then I wouldn't put you on end-tidal. But again, some people disagree because, like I said, I'm pretty sure Grady or maybe it's AMR. It's AMR requires that if you gave them fentanyl, you have to put them, or any opiate, you put them on end-tidal. So it's not crazy, but it's also easy to do in teaching world where they're free. Part of what it is this is where we're starting to get into the wheelhouse of understanding, simply asking people's medications. I ran a call once where sometimes people would suck on fentanyl patches to get all turned up. I ran a call once where a guy was sucking on a fentanyl patch. Essentially, it knocked out his respiratory drive. He fell backwards and then he was choking. So it was called as a choking call, but it was really an opiate overdose as well. So just know essentially that sometimes people have patches, nitro, pain patches, all kinds of things. And it's kind of like having a heroin needle sticking in the arm. Here you are blasting them with Narcan, wondering why it's not working. It might be a good idea to do a full head to toe, look for a patch stuck somewhere.
That's like prescribed?
Yeah, There's also suckers. I couldn't find suckers. I know Dilaudid is for sure.
I thought that should be like illegal though, because they can suck on it and get.
What? No way. What a buzzkill. Now, fentanyl is powerful.
The video
and it is
released last
dangerous,
week
right?
was dramatic.
Here we have 2 police officers. They found a bus.
After packaging up some fentanyl taken from a suspect's vehicle, The video released last week was dramatic. After packaging up some fentanyl taken from a suspect's vehicle, Deputy David Five Eyes suddenly stiffens and falls back. Almost immediately, his training officer, Deputy Scott Crane, administers naloxone, given to people who have OD'd on opioids.
Full-on dead weight. His partner whips open Narcan, takes sunglasses off, code cover.
The blowback came within hours. Medical professionals across the country saying what the video showed was not an example of overdosing on fentanyl, lashing out at the sheriff's department for releasing a video many said misportrayed a situation that plays out with deadly consequences across this country every day.
I think it's helpful to release the full version so that people can
overdose on fentanyl by brushing up against
much as you can see from a body cam.
Dr. Carla Marienfeld is the medical director of UC San Diego's Addiction Recovery and Treatment Program. She has not seen the unedited version of the video yet. With what she has seen, she says she doesn't feel comfortable saying what happened to Deputy Five Eye was an overdose. Marienfeld says she's more concerned about the unintended message the video could send.
I think the most important message is that people shouldn't be afraid
I'm sure he didn't know, and I'm proud of our police officers for being very aggressive in the treatment. What they need is some education. My wife just went through Cobb County's narcotics lecture. She did it 2 weeks ago.
One thing that is new from the unedited version comes when Deputy Five Eye is answering questions from a paramedic.
Any medical history you know about? Go into an overdose and stop breathing.
Boy, my 6 or 7. That's how much on my head.
That leads to an obvious question as to whether Deputy Five Eye has a history of fainting, and if that's what happened here. Dr. Marienfeld says, hard to tell.
I think that you want to take into consideration the fact that the patient may have had previous head injuries and whether or not some of what he was presenting with currently was related to him hitting his head in any way.
Then there's the question of a toxicology test. The Sheriff's Department now says one was not done at the hospital. Dr. Marienfeld says that's not unusual.
In the emergency room, you're trying to be as efficient as possible in helping somebody. In that situation where the story was consistent with a fentanyl exposure,
but
it wouldn't necessarily make sense
there's a reason why people wear those patches and aren't like,
system, particularly
like they go
if
on
the
about their
story you
normal
heard as
daily
the
living
physician
because
was
it's
that the patient responded to naloxone.
We reached out to the Sheriff's Department for clarification, but in an email they said they weren't doing any interviews today, leaving this story kind of how it started, with way more questions than answers. John Carroll, KPBS News.
50 micrograms per hour is this patch. Now, admittedly, that's a fake picture and I don't know a lot about. Well, that one looks pretty real. The point is that I think that misinformation is run rampant, you know, and I think it's especially propagated because police are largely isolationists, you know, they only want police teaching them essentially. Like they're going to be doing CPR over there. I'm like, how come do it for free? I'll do it like you ain't never seen it before. People are going to have a good time. They're going to learn a bunch of stuff. And they're like, not a cop. I'm like, do you want a cop doing it? Like, that's so, anyway. So don't worry about fentanyl. Also, you got Narcan, so don't sweat it too much. But these type of topical ODing instantly, I'm like, okay, look, I've been around a decent amount of drugs in my life. If it were that easy, they'd be a lot cheaper, I think. So take a quick break here. Oh, wait. This was him crying as he recounted the episode.
Wait, is it just a picture?
Because Medicine I wrote on sick for including sick pay.
So if we see a fentanyl patch, do we just take it off? You said.
Yeah, take it off and then wipe it, not with your tongue or your hand. If that's the problem, I guess I should be specific, because if your guy's having hypoventilation and he's got a opiate patch on, that should come off and you should wipe it off. If his issue is a headache, you ought to leave it on. Now, morphine, much like fentanyl, is an analgesic. It's an opioid specifically, which means that it's binding to mu receptors, opioid receptor sites, and it's having similar properties. There is a lot of conversation out there about one med or the other. I'll teach you what the book tells me to, which is essentially that morphine acts slower and starts slower. Whatever. I've had it affect exactly the opposite many times in different people. What this means in summary is, and really what we're building up to, is why would I pick one of these pain meds over the other? That's what you're really trying to figure out. Now, one reason why you shouldn't pick morphine, or that you'll need to be cautious of, is the fact that morphine releases or causes a histamine release. And we know about histamine release in association with what type of shock? Anaphylactic, which is also called what kind of shock? Distributive shock, vasodilation. Now, morphine doesn't always cause histamine. I can remember, I have never once in my career, admittedly I haven't given it in quite some time, but the first 2 years I worked in Flint as a medic, we gave morphine all the time. I never saw anybody's blood pressure drop. So, I don't know. In fact, I would come in and I would have a patient that I gave morphine to, and the nurses would often say, hey, did you give any Benadryl? An antihistamine. I'd say, no, why? And they're like, because you gave morphine. And I'm like, well, if his blood pressure drops, I'll give Benadryl, but I never had to. So more is the message here. We don't give it if they're hypotensive or hypoperfusing. And also be conscientious of the fact that it might cause that. Histamine release and that. So really, if you're on the fence between these two meds, I'd say, look, just use fentanyl. It doesn't cause hypoventilation. Or sorry, it does cause hypoventilation. It doesn't cause hypotension. In a certain sense, it reminds me a little bit of the discussion between aspirin and nitro. Aspirin is responsible for reducing mortality in acute myocardial infarction by 23%. Nitro is 0% association reduction. So if you're on the fence about nitro, don't give it.
So for nitro, like, I guess we have the contraindicator for nitro that's systolic under 100.
Yep.
Versus saying like hypotension here. Are we talking more about like MAP versus?
So it was tricky to write the card around that. Part of the reason is because we don't give nitro to kids, so I can say the systolic number, but we can give morphine essentially, which means hypotension is a relative term.
Sure. Yeah. Okay.
I don't know how to cut off the.
Apparently not.
Yeah, I know. It's the computer. I don't know how to do it. Fix it.
Yeah.
And I've had this.
I imagine Google does. So, if we're talking about opioid receptor sites and the binding of these things, morphine, fentanyl, opiates, naturally, they're binding to opiate receptor sites. And those are all agonizing those receptor sites, eliciting a response. Antagonism of that would be them binding to the receptor sites and then blocking the response. What med does that? Narcan.
I'm Googling it now.
My girl. And so put pretty simply, what I think is particularly cool about Narcan as an antidote is the fact that not only will it bind to a receptor site, it will also dislodge opiates, which makes it very effective. Romazicon for benzos, antihistamine, whatever the heck there's tons of antidotes. I only know a couple because they're the only ones we got in EMS.
Okay.
Here's a fun fact for you. If we give an opiate and they are hypoventilatory, we give Narcan. Right? I give fentanyl, he stops breathing. I'm like, oopsie, here's some Narcan, then he starts breathing again. Why? Well, because it's a reversal agent and it dislodged the opiates, right? No big deal. Well, as paramedics, we can give benzos, like Versed. Well, Versed also has a reversal agent. It's called flumazenil or romazicon. Nope. Well, we didn't even use it in the field as paramedics, even though such a thing exists. Do you want to know why? Because benzos are for seizures, and romazicon can cause seizures. And if you give a benzo to a person to stop them from having a seizure, you give them too much and they stop breathing, so you give them the reversal agent. Now, not only do you have a person who might seize, but they have a floating reversal agent, so they can't receive the benzo. Hence, we didn't carry it. Now, I only put this on here because Mr. King and Mr. Denner are going to end up teaching it to you in medic class. I want to say that Narcan largely is an innocuous medication, that all of these meds, though I only list IV, are all given SIV, slow IV, which by definition means over, I don't know, 2 minutes or so. But realistically, anytime I just mean, usually when somebody would get on the truck who can give IV meds, they'd say, how fast should I push this? And then I would just grab their arm and I would just slowly squeeze it. So even though they'll give some long amount of minutes for slow IV, I just mean over the course of a few seconds. That's a slow IV push. There's only one med that we give fast, and that's in paramedicine, it's adenosine. So, what? I have no idea. In fact, I've looked up the articles surrounding pulmonary edema and dysrhythmia's association with Narcan, and they are few and far between. But part of this is me prepping you for those classes where that is one of the known adverse effects. I don't really care that you know it. Those both happened because they either had a pre-existing dysrhythmia or that it was pushed way too fast. So if you don't push it like you shouldn't, it's probably a non-issue. But I have no idea why it caused that, and I barely care that you know that. Neonates. How would you know a neonate needed Narcan? The parents were addicts. Right? Which is fun, because now we know a little bit about that and a little bit about Destiny. Yeah. It's just a lot of learning going on in here. Now, what you'll hear in the field sometimes is that people will say that people will essentially will do one of two problems here. They'll be like, dang, that guy is breathing 3 times a minute and little snot bubbles are coming out. Let's get some Narcan going. Just grab their little package. The guy's like, grab their little package, getting it ready, starting a line, wherever. I'm like, he's not breathing. What are you doing? But on the other side, we'll get people who will make the mistake of saying, wait, he's not having a problem with a lack of Narcan. Don't give him Narcan. He's just ODing. Just bag him the entire time because he'll wake up if you give him Narcan. My message to you is BVM first, but not in place of Narcan. Nobody should be surprised to learn that giving Narcan as a reversal agent, which now lets a person control their own airway, is far better and safer than me doing it for him. How often, can you give a percentage, how often does using a BVM with an OPA, how often does that put air into the stomach? 50% of the time. Okay, 50%.
Wait. If I have open airway with a BVM, you ask me
100%.
Yeah.
100% of the time. Why is it a problem when I'm ventilating somebody that I'm putting oxygen or air into their stomach? Barotrauma is a possibility.
Is it because they're not going to be breathing out CO2?
It does. It's essentially not ventilating them if it's going into the stomach. Sam? It might cause emesis. These are all great answers. Absolutely. It's increasing intrathoracic pressure. As I fill up the balloon of the stomach, it's allowing less pressure for the air. But it's all we got at this point, right? It's part of the benefit. Thank God now as AEMTs, we can throw in an eye gel and put it just in the lungs. So when people are like, oh, don't give him Narcan because he'll wake up, just BVM on the whole way. First of all, most difficult skill you will do in EMS, for paramedics as well. The most difficult skill you will do is a BVM successfully. Number 2, it's not an innocuous intervention. It causes barotrauma, aspiration risks, insufflation of the gastric system, and so therefore intrathoracic pressure increase, and all kinds of things, where all I got to do is give them this little tiny med, And suddenly he's got control over his own airway. I'm into that. Yeah.
And that's a two-man job.
And it's a two-man job. That's right. Quick conversation about eyes, specifically pupils, remembering that mydriasis is the dilation. There's not a lot that affects pupil that isn't light, drugs, or trauma. Now, one of the most common misconceptions is that students will say, okay, well, his pupils are not pinpoint, therefore this cannot be opiates, and that is not true. Sometimes you get pinpoint pupils with opiates. Sometimes. Which means that you can use it as a rule of inclusion, but not one of exclusion. What I mean by that is you could say, hey, my patient's not breathing very well. I'm going to check the pupils. Oh, they're pinpoint? Let's roll with some Narcan. What else would do that? Not a lot. What you shouldn't say is, oh, my patient's not breathing well. I'm going to check the pupils. Oh, they're not pinpoint? Get that Narcan away from me. You absolutely can. On the reverse side of that, it turns out if you take opiates for long enough in a chronic situation, you will live with pinpoint pupils. Where this can happen is you've got a guy, he's 70 years old, he's been taking codeine for a back problem that's lasted him 20 years or whatever, so every day he takes his pain pill. He's got sciatica issues, a hip problem. So he takes pain pills. Today he's not breathing well, he's got pinpoint pupils, you give Narcan, nothing really changes, it wasn't his issue. Everything's dots creating a line for us, right? I was on a truck with a fella. We had a guy, it was a geriatric patient, pinpoint pupils, long med history, hypoventilatory, we're bagging. My partner gives him Narcan, 0.5 milligrams IV. The guy gets way worse, almost stops breathing completely. What happened? What did my partner do? No, he was fine. Nope, he pushed it he gave it completely correctly.
What was that?
He gave it IV, it was 0.5 milligrams, gave it nice and slow, even with a pinky up.
One thing that was keeping him from breathing.
My partner said, essentially, yeah, my partner said, oh, it didn't work, let's get more. And I'm like, no, nothing happened. They got catastrophically worse when you did something. Doing it again is not the answer. What? Don't get me wrong. If you have more opiate molecules than we gave opiate antagonists, sure, you might have to get more. What I'm saying is she was having a hard time. We gave the protocol dose of Narcan and she almost died from it. And his thought was, let's do it again. What we would later find out, I was like, no, thank you. I don't know what's happening, but that can't be it. You were fine before I got here, basically. Now you're almost dead. Essentially, what we would later learn is that she was in some type of metabolic failure. Her organs were shutting down for a different issue, and she took chronic and daily opiates. So in the middle of her medical emergency, we were throwing her into withdrawal. So again, I think it's one thing to kind of be like, the Narcan didn't really have any effect. Let's try it again. It's mostly innocuous. Give it nice and slow, no big deal. Well, if it didn't work again, then it wasn't an opiate. I've never seen it take more than that. Additionally, if they get way worse, you got a different problem now. It just goes back to that poor fellow falling out, just getting Narcan after Narcan after Narcan. I'm like, no, dude, what? You got to know about a host of meds that aren't included in your scope. These are your sympathomimetics, things like cocaine, meth, and so on. Largely stuff that takes you up and dilates your pupils. I got test questions coming that says, your patient is on cocaine, what should you suspect? And bradycardia will not be the answer. There are medications that slow you down. Alcohol, opiates, barbiturates, and benzos. These, some other type of med that's rarely used anymore. And I hate pronouncing too many R's or something. Barbiturates. But I know very little about it. Actually, nothing about it, other than it's a CNS depressant has too many R's. Really what we're talking about are the toxidromes, and these are the meds that the categories you have to know, essentially. Uppers, downers, wetters, and dryers. And this is the most succinct version of this I can give you. You're basically looking at a quadrant system, trying to figure out, based on the symptoms that have appeared, where does your patient fall, and therefore what do you need to do? Now, alcohol is an interesting animal. If I just said, is alcohol a stimulant or a depressant, you would be reasonable to say, well, it's technically a depressant, but what part of this are you asking? Because withdrawal of it falls on one side, and overdose of it falls on the other, and that is another important distinction. And in fact, that's where the test questions will go, and some of your patients as well. Some dude will come in, he'll be all dried up and hot and tachycardic, and you're trying to ask, okay, is this an anticholinergic issue? Did he take too much Benadryl, or is he going through withdrawals? Now, your number one way through all of this isn't even memorization of the presentation. It's a good start, but really, it's context clues. Your guy has been out farming all day, right? Your guy is in the insecticide portion of Home Depot. Your patient takes scopolamine or Benadryl. Like, kind of piecing through the history here is going to help you more than anything. Tati?
So I have a question. I don't know if this is like getting too ahead. So let's say that you have someone that's kind of like doing both. Like, you know, as we see a lot of like cocaine, like someone doing cocaine and like alcohol.
Yeah.
They're doing both the stimulant and the depressant.
Speedballs.
So does that change your treatment?
Definitely. Dude, they were the most fun in the world. So the question is about essentially what I would refer to colloquially as a speedball, like somebody that does heroin and cocaine. Dude, they're so much fun. They're very dangerous, but they are so much fun. They make cops crazy. Essentially, you come in, the guy can't breathe, so you give Narcan, which means essentially the opiate's not working anymore, or the downer. And so then all of a sudden the stimulant takes over. He starts losing his mind. So I give him benzo to calm him down. Well, he stops breathing again. And it's just back and forth, back and forth. And every time you push the med, he just turns into a different person. It's a lot of fun. It's super dangerous, both for your cardiovascular system and your breathing. Now, to put a lot of these medications and antidotes to bed, it goes down to like this. You know, there's several of you that have been like, man, I'm just so overwhelmed. There's so many different drugs, so many different interventions. And I'm like, right. What you're concerned about is a bunch of conditions and treatments that you don't have access to. Stop worrying about that. Do you have a reversal agent for stimulants? Right, which we don't have as a medic or as a EMT. You don't have a reversal agent for a stimulant. It's more to the point, I would make the case that you definitely shouldn't be using ketamine for it, even though maybe I would as a medic. So if you don't have a reversal agent for stimulants, I don't expect you to do a whole lot. Now, I do expect you to treat their condition. If they're overheated and they're tachycardic and dehydrated, sure, well, we got fluid for that, right? But there's no med. So in that case, it would just be like if you're on the fence about a person who might be having a stroke but also has low blood sugar, I'm like, treat the one you can prove, or at least the one you highly suspect. And so in a case where maybe a guy said, yeah, I just did a bunch of coke and I did a bunch of heroin, I'm like, okay, well, I'm giving you Narcan if you stop breathing. You talking to me about how much drugs you did doesn't bother me a ton. But if you stop breathing, I'm going to give you Narcan. Does that make sense? Just treat the one you can. So make sure that you know about alcohol essentially being a CNS depressant. And of course, it's the same reason that it's a CNS depressant that the withdrawal of that comes with a slingshot effect, right? If I am drinking hand-to-hand here, fine. If I am essentially hand-to-hand and I'm constantly under a daily weight of a depressant, I'm just drinking chronically and heavy, usually all day, every day, and then one day I stop drinking, my body that's been fighting against bradycardia, bradypnea, and hypotension suddenly doesn't have the depressant anymore, so I become the reverse. I become tachycardic, tachypneic, hypertensive, crawling out of your skin, itchy, red face is a dead giveaway, that flushed skin.
So you start off down, and then when you stop, you go up.
You throw a couple of cocktails into me and it will take me down for sure. If I kept doing it every day, all day for a period of a few months and maybe even years, you get used to that kind of stuff. And then one day, all of a sudden, I've seen it in one day with people. Like usually they drink all day, every day for the last 5 years, let's say. And today they didn't. They said they were going to quit. And so in 4 hours after that, they had a seizure. They were red head to toe, just having a real hard time. It's tough. In fact, heroin, so far as I know, heroin and alcohol are one of the two things you should never cut cold turkey because they can kill you. I'll get people all the time, they'll be like, I'm detox situation. Absolutely. But it's hard to tell an addict to say, hey, don't stop, just slow down. It's like, yeah, right. The next thing you want to know, essentially, is difference between cholinergics and anticholinergics. As a summary, cholinergics make you leak to death. out of your colon partly, right? That's how I associate it. With cholinergics, we're wet and slow, essentially. With anticholinergics, we're dry and mad. So made, huge made. It will be very important for you to, I like dumbbells because I think it hits all the spots I want it to. It includes bradycardia. Sludgem doesn't, and I think it's an important distinction. Now, I will admit, I think it's a little heavy-handed on the bradycardia thing. I think what people think is, oh, if I take an organophosphate, I'm going to be at like 30 heart rate. I'm like, it's often normal. What'll really catch you is when a person is having a medical emergency that should maybe be tachy and aren't, because they're taking a parasympathetic, I don't know, hormone, probably? Certainly. Now, what this means is you need to be able to commit to memory that cholinergics make you leak to death, they make you wet and slow, that organophosphates is one of the big associations. I had to Google the other one because all I could think of was organophosphates. But nerve agents like sarin gas, I've seen that on a test somewhere too. I don't remember where. Yeah? Yeah.
There were like 6 options. It was like, which ones are nerve agents?
There you go. Which one are nerve agents? I knew I had seen it somewhere. I wasn't sure if it was registry-wise. So that means if I got a test question that says, which of the following are cholinergics, you're looking for organophosphates and nerve agents like sarin. I don't know any other ones. I just put that one down.
So just sarin.
I'd say nerve agents. I don't expect you to know a bunch of... I mean, did you pass registry? Yeah. Yeah, so obviously it doesn't matter a whole lot. So the point is, unless you knew...
I knew sarin, but that was the only one I knew.
Well, that's the only one I put there.
I know sarin, that's
Great.
it.
Yeah. Well, I just think back to my career and the amount of times I've had to deal with cyanide poisoning and sarin gas. So many. Anyways, your big takeaways here is wet, slow, dumbbells, or sludgem, that essentially you leak to death. And the anticholinergic is the reverse of that. Antihistamines will have, they're not technically anticholinergic, but they do have a lot of profound anticholinergic effects. And the other are tricyclic antidepressants, which are less common now, admittedly, and also I don't know a lot about other than the fact that they're brain meds that help you with depression. But if somebody takes an overdose of antihistamines or tricyclics, I know that they are going to be experiencing an anticholinergic toxidrome. The crux of this is going to be you trying to figure out on all of this stuff, essentially, what's the defining feature that makes it not be the other things. The big one here is skin, because you'll come up to a person and you'll be like, oh, they're altered, they're agitated, they're tachycardic, their respirations are up, they're both, but the one will be sweating, the other one can't. You say why? Dry, sure. But if she said why, I would say, I'm so glad you asked. If you think about it, right, our adrenal system is what's ramping us up to fight in part, right? Whoa, do I want to go down that rabbit hole right now? I do not think I do. I think we should tiptoe up to that line. But if I was trying to study this stuff, I'd be like, okay, wait, a lot of this information from side to side is the same. So what's different? That's the part I have to remember. If I can remember that I leak to death and essentially that makes me cold and wet, then I can remember that the anticholinergic is the dry and mad, and that everything is up, up, up. The distinction is between a stimulant that will make me sweaty and an anticholinergic that won't let me. When it comes to alcohol, it kind of falls in these categories. Of course, it doesn't have any pupillary effects, but so long as you can remember essentially alcohol exists in these two quadrants, I think you'd be fine. What might be a helpful reverse association is that if you struggle with anticholinergics, remember that it looks almost identical to alcohol withdrawal. Or else. Nitrous oxide. Of course, he's getting a whippet right now. I don't want to talk about nitrous oxide, especially now that we have access to all these opiates. This used to be the only pain med we would teach AEMTs. And my card used to say, this drug is dumb, just let the patient hold it so they don't OD. That 50-50 nitrous oxide is essentially 50% of that they're breathing in is nitrous. The other 50% is oxygen. What up?
I heard that nobody's, well, I mean, like EMS-wise, is allowed to use that in Georgia. Is that true? Or is
Probably. I don't know. Georgia has a very narrow scope for AEMTs.
No, I mean like medic, like any truck, like weapons.
I don't know if they're not allowed to. I've never worked at a place that had a protocol for it, but part of the reason is, oh no, where's my, is it takes cans. It takes this little motorized thing and a big can of nitrous and a big can of oxygen. Like, where the hell would we put it? Or we have so many other access to meds that there just is no point in utilizing it. So they put it in a dentist office because all you have to do is put it on a person's face, and if they OD, you take it off, so it's pretty innocuous and easy to correct. What? Definitely.
Yeah, I just didn't know that they were, you would just like overdose and they're like, oops.
Yeah, totally. Yeah. Because essentially, it's not technically an opiate, it just does something with opiate receptors. And so it can give you a sense of euphoria, but since the body is already breathing in 70% nitrogen already, it handles it really easily. The antidote for nitrous oxide is ventilation. Because if you breathe, you just breathe out nitrous. Now I know that because I love science, and one of my favorite things is the Call of the Deep. Oh, yeah, which talks about nitrogen toxicity, but I also knew it because I did a bunch of whippets when I was younger. And if a guy went out and he wasn't coming back, count to 10, he'll be fine. It's not super spooky. But unless you're in a dentist office, you're not going to interact with this stuff, partly because it takes a bunch of cans. As to whether or not EMS is like forbidden, it's probably just not practical. Landon, do you remember your question?
I think it was along the lines of the Call of the Deep. Like, isn't this essentially the bends that you're giving them? Because you're giving nitrogen in their blood?
No.
Oh, no, because it's being inhaled, isn't it?
Well, no, it's not the bends, because we're talking about nitrogen getting into the brain and causing altered mental status, not any other issue.
Okay.
But you're in the right chapter for sure. So, ketamine is interesting. I got a love relationship with ketamine. I love it at work. I think recreationally it is unwise. Weed is basically legal in most states. In a world where that's true, ketamine is an interesting thing to me. Ketamine does not work on opiate receptors. It works on something called NMDA receptors, and those can be found in your spinal cord and also in your brain. Now, unlike opiates, it's not so much changing the pain receptors. Those are done through the pain receptor sites, the opiate mu receptors. It's largely changing the way you think about pain. And so there are some protocols out there that will say if you're using ketamine for pain management, you should also give an opiate, right? There's certain things like benzos that will be what we call retrograde amnesiacs, which means if I walked up and I said, how do you feel, gave you benzo and then smacked you in the mouth, like 3 minutes later, you'd be like, why does my face hurt? Because you will have forgotten I gave you an amnesiac. Ketamine is an interesting thing where when it binds to these receptors, different places in the brain, essentially, it changes your perception of things. This is like I was talking earlier. There are certain things like psilocybin mushrooms and LSD that it kind of disassociates you to a lesser degree, meaning suddenly you are kind of aware like you're floating outside of your body is kind of what those psychogenic drugs will do. Ketamine cuts that wire, right? I mean, I can remember times essentially where I had experienced that, and I remember being like, God, look at that guy on the couch. He's freezing. Oh my, somebody should get that guy a blanket. That is so horrible. And it was like 10 minutes later, I was like, that's me. I'm looking at myself. I'm freezing, you know? But I couldn't talk, you know? I was outside of myself, you know? It all involves a long discussion about what perception is and what consciousness is and da-da-da-da-da. What I'm saying to you is this clinically. Ketamine is a dissociative. And so I do think that if a tree falls in the woods and no one hears it, it made a sound. If a tree falls, it moves a bunch of atoms, they bounce off all the walls, so you weren't there to hear it. That still happened. My opinion of ketamine is, for pain management, is that your body is still undergoing an adrenergic response to pain. Prostaglandins are being released, your heart rate is going, you're experiencing it. Just because I changed the way you think about that pain doesn't mean your body's not experiencing it. And so I would argue, essentially, that we could give ketamine and something like maybe Toradol to help their body kind of release that issue. Now, one of the distinctions that I make on the drug card very specifically is that though it is a dissociative and it's in the paramedic scope to give it for agitation, we are never doing that. We as AEMTs don't have in our scope sedation orders, okay? And so be very careful. If you got a guy that's losing his mind and cranky as the day is long, if you find some way to give him ketamine because he's in pain, fine, but you're not giving it to sedate him. That's not what we're doing it for. It's a different dose. Yeah?
If we do have a guy like that, what do you do as a A?
As an A, you call for a paramedic and tackle him to the ground.
Perfect, thank you.
Sweep the legs. That's my recommendation. Yes, ma'am.
What is NMDA?
I have no idea. We can Google it together. N-methyl D-aspartate. Now it's on the test. So, no, I don't know, do they? I'm pretty proud of myself for knowing that it binds to, yeah, right. Everyone can thank Miss No. Well, it'll be the easiest one on there. But no, I'm not doing that. If I don't know what it is after this long of a career, I don't care that you do. Now, there's a couple of things to talk about here. Firstly, is it's one of our only meds that we give over time. Here's my message to you. You learned a bunch about med math, and I'm real proud of you. Time to learn more. Just kidding, I don't care. I'm not going to have a quiz or test question that asks you to give a med over time. But if you do it in a scenario, you're going to have to know how to do it, or else you're not going to do it right.
As a A, we don't do medication for like...
There is a line around 10 minutes where, depending on which website you go to, they will call it a bolus or a slow infusion. What I'm telling you is I'm never going to test you over how to figure out drops per second, and I highly doubt the registry will either.
So it's more about choosing the right one, like micro and...
I would say this, actually kind of the exact opposite. You will never use a micro drip in here, especially with meds over time.
Because we are A's.
Yes, because we're A's, but because we're talking about small amounts of time. 10 minutes? Dude, if we used a 60 drop set for this, I don't even, well, we could do the math on it. It wouldn't be that hard, but it would be a lot of drops, uncountable. In fact, when I give, even many of the meds that I would give as a paramedic, like amiodarone is given over 10 minutes, basically I just put all my 10-minute drugs in a 500 bag and run it wide open, and then literally you're just timing the bag. At 2 minutes or so and be a quarter down, well, a fifth down, and then at 5 minutes, half the bag, and if you're a little too far, you slow it down. Look, I'm okay with that. But the reason why I want to teach it so that you, just at least so that you reference it. But again, I'm not going to have a test question on it. I don't super care. In summary, this is how the math is done. I take my volume, I multiply it by my drip set, and I divide it by my time in seconds because I'm counting drops in seconds. Well, no. You don't, well, if you're going to use it, like you can't give ketamine essentially without giving it over 10 minutes. So I'm not going to have a test question on it, but if you want to goof with ketamine in a scenario, then you'll want to know how to do it. If part of you is thinking, well, Mr. Farron, why are you being vague on that? I'm like, because I don't care if you know how to give ketamine. I really don't. What I care about is that you leave this class and you know what it is and why to give it. I don't care if you have any experience giving it. I think that's on the cutting edge of your scope. I just want to make sure that if you get a question where the registry says, which of the following blahs, and the right answer is ketamine, you don't say, well, that's not in my scope. So you essentially do your volume. If I said 100 mils, that's 100 mils times your 10 drop set, essentially, which is 1,000. You divide it by how many minutes? It's over 10 minutes, which is 60 seconds times 10, so it's 1,000 divided by 60, which puts you, I was going to say 2, because that's what I remember, but 1.7.
And
That's it.
in practicality, 2 a second. Right.
In practicality, 2 a second. This is what 2 a second sounds like. Oh, do I have audio going? I don't know. I don't really want to factor it out. But essentially, we can count it out, right? So you're watching that drip. It's not wide open, but it's pretty fast. I am very okay if you were running ketamine in our scenarios, essentially, and you say, I'm going to turn that valve to about halfway. And then in 5 minutes, you look at it, and I say, hey, how's my bag? Is it about half empty now? And they're like, no, it's a little more than half. You're like, cool, I'm going to slow it down. I'm okay with that. I don't think you're going to get a med-math question over time on the registry, but this is how it's done. And quite frankly, honestly, I think by the end of this class, it'll be more convenient to do the math because it'll be simple to you. Bag, drip set, 600. That's it.
We literally start medicals with that kind of stuff in school.
Yeah, it just takes time. Students are like, whoa, so much going on. And I'm like, yeah. But you got weeks to learn it. Now, 2 things can happen when the administration of ketamine. I've seen it make people real tacky, don't know why. Mostly geriatrics, real tacky, not sure why. Usually I've given ketamine as a dissociative or subdissociative dosing for people who were agitated. My suspicion was always that, again, that disconnect wasn't working properly. If you're going to give ketamine to somebody, you send them to their happy place. Like coaching BVMs on awake people or CPAPs, right? I say, hey buddy, I know you're hurting. Here's a good example. And this will come down in the end. Why I even give ketamine for pain is if the pain is making them crazy. That's why I give ketamine. Like if their whole body, if they're burned up, dude, sometimes fentanyl, morphine don't touch that stuff. I gotta disconnect your mind. I had a fellow once, he was over 300 pounds. He had broken his femur. I was just me and a partner and like 2 firemen on scene. We couldn't lift the guy, we tried. We had to get him onto the bed. We couldn't get him out of the seat. So I gave him ketamine and asked him to stand on his broken leg, and he did. I needed him to be disconnected when he experienced that, right? Now it was dangerous, he could have had a laceration of the femur, but again, EMS, I'm like, I couldn't get him out of the house. I didn't know what to do. I had to have him stand on his own broken leg. It was weird and crunchy. Ketamine will do that for sure. Fentanyl will not do that. Fentanyl will knock you unconscious before it gives you the ability to operate through a broken femur. But ketamine's like, what femur? And so when I give people ketamine, this is often how it's done, right? I throw it in the bag, I'm starting it to drip in, and I'm like, hey buddy, just a couple of questions here. Say your name for me again. Landon. Hey, if you could live anywhere in the world, where would you live? Did you ever go on vacation? No, you've never been on vacation? I like Northwest. I like the cool air. You a beach kind of guy or a tree kind of guy?
Trees.
Trees. What do you like about the trees? Yeah, I'm just walking them through happy memories. Because when you go into ketamine, essentially, you will take with you the trajectory that you started with. The amount of times I've heard people give a bad rap to like psychedelics and stuff, most of the stories start the same way. Tried mushrooms for the first time and it was horrible. There I was in a strange place surrounded by strangers. I'm like, well, okay. Right? And so ketamine is much the same, where I'm like, hey, look, you've been married for 14 years. You guys getting along? Yeah, dude, she's my whole life. I'm like, what's her name? Da 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 da. You're gonna die today. Goodbye. You know, just no. Don't do that. Anyways, you got to set them up for success. Now, in rare instances, they can experience laryngospasm from ketamine. I don't know why. What I do know is that by performing the Larson's maneuver, you can release that laryngospasm. If any of you has had an older sibling, you know exactly the place I'm talking about. It's essentially right underneath the ear, right on this jawbone. You'll know you're in the right place because if you put any amount of pressure there, you will hate your life. And so essentially, if I get a person ketamine, I move them over to the stretcher, I notice they're hypoventilatory, that he's not moving any air. I'm like, holy moly, he's not breathing. He might have experienced a laryngospasm. I hook up underneath that, and it will essentially release the pressure of the laryngospasm. Crunch, crunch, hook. Whoosh. Had to make my own sound. So when the question comes like, well, I got a bunch of crap that I can give for pain, why would I use one or the other? This is kind of my summary. Look, if it's an obvious inflammatory process, well, we want to use an anti-inflammatory. That makes sense. Fentanyl and morphine don't have anti-inflammatory properties. They do nothing for that other than blur the pain, but they do nothing for the physiological response. So pretty naturally, generally speaking, if it's mild pain or discomfort, ketorolac's not a bad deal. If they're addicted to opiates, even if it's severe pain, maybe ketorolac is the way to go. If it's moderate to severe pain, I recommend fentanyl. It works fast, doesn't last very long, it's easy. It also doesn't have histamine effects, which keeps you out of the woods of morphine. If the pain is making him crazy, right? Here the guy is, he's got a broken arm, and he's just, I'm like, hey buddy, look, we're gonna get you some fentanyl. We get you, no, please, please. I'm like, oh, all right, it's time to turn you off, right? So put pretty simply, what you're really trying to decide is, if I just give people fentanyl, when am I really trying to give ketamine? And the answer for that would be if they are just losing their mind. Alanis?
That's where you draw the line.
Yep. That is where I draw the line. I don't have a lot more to say on that other than anecdotal experience will pave your way. You'll start using fentanyl and realize what it can and can't do, even though it changes wildly between people. But the biggest question I get about when to use ketamine is essentially if fentanyl is doing it. I would also argue that if you're doing ketamine, they probably should get another pain med.
If I do fent, can I do then ketamine?
Yep.
It's not working? Okay.
Yeah, dude. Throw the whole box at them. No. Yeah, dude, I remember when I started the career, I was like, they're going to call me the candy man, dude. I'm going to give them all meds. Absolutely. Absolutely. Respiratory agents, which truthfully is very little about the albuterol and Atrovent you already know. We're going to break down the autonomic nervous system. So let's take a break, because I get lonely when Sebastian's gone, and we'll pick back up on autonomic nervous stuff. Okay, let's talk about the autonomic nervous system. I think what people incorrectly think is that the autonomic nervous system is a lever that pulled to the left involves the sympathetic and then pulled to the right involves the parasympathetic, when in truth, there are two separate levers because they're two separate systems. The sympathetic nervous system can be agonized, and so can the parasympathetic. And generally speaking, when one is agonized, it has opposite effects if agonized on the other. Meaning if I agonize my sympathetic nervous system, I'm going to get bronchodilation. But if I agonize my parasympathetic, I'm going to get bronchoconstriction. Which means if I want bronchodilation, I have to agonize the sympathetic and then what? The parasympathetic. Antagonize. That's a duoneb. People often refer to these things as gas and brake pedal, which I think is a good metaphor because it allows you to kind of think not one pedal, not like, well, I press harder, go faster, take off, slow down. If I'm in a car and I push both the brake and the gas pedal, I don't go fast and I don't stop. I do this weird chugging somewhere in the middle, right? Which means that if I push the gas pedal and the brake pedal and I said, hey, I want you to go faster, you can make a choice on one of two systems, at least. You can either push harder and agonize the gas pedal, or you can antagonize the brake pedal and take that off. But in either case, you will go faster by working opposite directions because you agonized or antagonized. Now, for our sympathetic nervous system, I care a lot that you know that alpha 1, beta 1, and beta 2 are the receptor sites for the adrenergic side, for the sympathetic nervous system. Muscarinic 1, 2, 3, don't care that you know that. We can just refer to these generically as the parasympathetic receptor sites.
You need to know like what alpha, beta, and all
Yep.
that does. Like
Yep.
what they do.
Yep.
What do they do?
None of your business.
Oh.
As an example, autonomic nervous system stimulation will cause bronchodilation. But if we agonize the parasympathetic nervous system, specifically those cholinergic receptor sites, it'll cause bronchoconstriction. In your book is a little chart that is full of a lot of information I want you to know. I have it highlighted here. I don't care that you know what alpha 2 is, to be honest. If you asked me before this lecture started, I couldn't answer. I have no idea. What I care is that you know that alpha 1 agonist is going to cause vasoconstriction. What I care is that you know that beta 1 refers to the heart and beta 2 refers to the lungs. You with me so far? Kendall?
Said beta 1 is lungs.
I saw you put in that homework at absurd o'clock this morning. It popped up. I answered it immediately. I'm like, we looking at the same moon right now. Beta 1 increases our heart rate, and that was fine enough for EMT. But we're big boys now. We need to know all the other tropic hormones.
Are we really?
We're wearing big boy hats, at least. You with me, girls? So, we know... Just all girls? I'm an ally, what can I say? Increased heart rate, but also all the increased tropic hormones. Chronotropic, inotropic, and dromotropic. We'll get into that more in cardiology, but for now, make sure you know that the beta 1 largely increases your heart rate and your stroke volume, which is the formula for what? Cardiac output, which would be the cardiac version of tidal volume, kind of, minute volume.
Yeah, you don't have to make it better something.
I wasn't trying, my dear, but also know that beta 2 is bronchodilation. You just, even if it was a wrong answer, conceptually you were not that far away.
Okay, great. Thank you.
So, do you remember us talking about cholinergics? How do they make you? 2 words to summarize cholinergics.
Wet and slow.
Wet and slow, which is, I don't know. That's the way it is, right? Sludge 'em, dumbbells. It makes you what to death? Leak to death. It also causes bronchoconstriction. So if I were to give an adrenergic, like epi, it would agonize the sympathetic nervous system. You with me? If I gave a cholinergic, which is the parasympathetic hormone, like acetylcholine, and agonize it, it does the opposite.
So can we like say that it's slow so it constricts?
Whoa. What did you ask?
What do we need to know that just that it constricts its
I think that if you can memorize alpha 1, beta 1, and beta 2 and what agonizing those things do, then you know what antagonizing those things do. And if you antagonize alpha 1, beta 1, and beta 2, it's the same as agonizing, largely, the parasympathetic receptors. I think that kite will catch wind. Now, histamine specifically isn't a cholinergic, it's not a parasympathetic hormone, but it does cause bronchoconstriction. And so if histamine is causing bronchoconstriction because it's binding to histamine receptor sites, and you have naturally acetylcholine being released because your body's always releasing a parasympathetic hormone, then we are suddenly going to have trouble breathing, yeah? Because even though I have epi, norepi, and these things floating through our body, and I have acetylcholine that's floating through our body, if I have histamine suddenly, now I'm doubling down on my bronchoconstriction effects. Which means that I can fix this problem at least in 2 ways. What's the first way? I can pull this lever harder by engaging my sympathetic nervous system. I can press on this gas pedal harder. What's the other thing? That's right. I can give something that antagonizes this effect, right? Now, I can also remove the histamine or give epi that's going to counteract histamine. Blah, blah, blah. There's a million different ways, right? Not be outside, not get stung by a bee, like whatever. Things like albuterol and epi, they are adrenergic, meaning they work like adrenaline. They work on our sympathetic nervous system. And we call them sympathomimetics. They mimic sympathetic hormones. So adrenergic and sympathomimetic are synonyms.
So they're the same?
Yep. If I said something is a sympathomimetic, does that mean that it is also an adrenergic? Yes, it does, or at least as far as my understanding goes. If I give somebody an adrenergic, does it mean I have given them a parasympathetic, parasympathomimetic, I mean?
No.
As far as I understand, yes. Oh, I'm so sorry. Yeah, you are correct. Good job listening to me, all part of the trick. So, if I give somebody an adrenergic, is it the same as giving them a sympathomimetic? Yes. There we go. Absolutely. Now, we can also lyse, to slice. So, saying essentially that something is a sympathomimetic is to say that I'm instigating and agonizing my sympathetic nervous system. If I were to say, give an adrenergic, that's agonizing, encouraging my sympathetic nervous system. But if I give a sympatholytic, it's still working on the sympathetic nervous system. It's just not allowing those receptors to be binded with. But it's all those terms are all on the one system. So in this case, if you're following along, originally I had some sympathetic hormone just naturally in my body and some parasympathetic hormone, but ultimately I was in homeostasis despite those two hormones in flux. Now, in the middle of the day, they might be largely equal, and in the morning your adrenaline might be kicking up as your sympathetic gets you ready for the day, and at night your parasympathetic takes over, but largely you just have an influx and movement of sympathetic and parasympathetic hormones basically adjusting to your daily needs or your acute needs.
Do we have a medication that's a sympatholytic?
No, and I don't know one. So in this case, I've got a little bit of adrenaline naturally flowing through my body. I also have some acetylcholine using as a chemical mediator. But today I ate a strawberry, and that's a problem because I'm allergic to strawberries, which means histamine has been released. Now I have widespread response to histamine, including bronchoconstriction. Since I already have a circulating cholinergic causing constriction, this histamine is making me have a bronchospasm and mucus is building up. Now, I give albuterol because it works on the sympathetic nervous system profoundly and powerfully, but I also give Atrovent, which is doing nothing for the sympathetic nervous system. It's just stopping the already existing parasympathetic hormone replace. The most succinct way I've ever heard this described is kind of that albuterol dilates your bronchioles, and Atrovent prevents them from constricting. That's the most concise way I think I've ever heard that described.
Atrovent prevents them?
Because it's not a pro-sympathetic, it's not an adrenergic, it's an anti-cholinergic. It's the it's opposite, which gets the same results. Because I can give a sympathomimetic to cause bronchodilation, but I could, if such a thing exists, give a sympatholytic to get constriction, or I can come over here and do the same in the opposite, because it's a different system and works in the opposite way. Now, we're going to talk more about an airway, but here's what's absolutely fascinating when it comes to albuterol. My number one message to you is if you suspect wheezing, go ahead and give albuterol and Atrovent. You got it? Yep. Okay. When it's safe afterwards, apply N-tidal and verify that you should have given albuterol. What I'm not saying is smack that albuterol out of your hand until you get N-tidal. That's not what I'm saying. If a guy's got asthma or he's got difficulty breathing, you auscultate wheezing, I say send it. Send albuterol. However, if it's a geriatric man with a history of heart failure who has pink frothy sputum and you hear wheezing, maybe don't send it, because you know better now. Why would giving somebody an adrenergic like albuterol who was not having a bronchospasm be a bad thing? Maybe not deadly, if I'm being honest, but certainly not a good thing.
It just doesn't help with CHF.
It doesn't help his problem, which is true. Pam? Don't shake your head or give me that pouty lip. I'll walk you through it. You ready? Okay. Which system does albuterol work on? Sympathetic or parasympathetic? Hang on, Pam. Sympathetic, parasympathetic? It works on the sympathetic. And things that are adrenergics, sympathomimetics, what do you expect kind of effect they would have on the heart? If a bear jumped out of the woods, do you think your fight or flight system would rock and roll? Right? And so if I'm giving an adrenergic or a sympathomimetic, essentially I might increase their heart rate. Why is that? Sam, if I got a guy tripoding, pink frothy sputum, I hear wheezing and give albuterol, why might that be a problem for him? Because his heart's already failing and now I'm telling it to work harder. What's the indication for albuterol? Bronchospasm, not wheezing. Because wheezing can be from rhonchi, rales, or bronchospasm. In this case, I've got a guy experiencing, again, let me back up and make sure, unless you got your classic tripoding history of CHF, pink frothy sputum, I'm okay with you starting with albuterol and then verifying with end-tidal. I'm not saying withhold it, okay? But if I think this is a CHF pulmonary edema issue, albuterol is not your first-line treatment, even if you hear wheezing. And this is the transition we have to make from EMT to AEMT. This is bronchoconstriction. This is the physical muscles constricting, spasming. Because that's what asthma is. It's a reactive airway disease where they clamp down, and albuterol works on these receptors to force them to dilate. With me? Now, you can make a whistle sound, a wheeze sound, because you have a spasmed, right? Just the interior lumen is smaller because the outside is squeezing in. But also, if you have fluid or mucus making the interior diameter thinner, it can also make a wheeze sound. The difference, of course, is that one of those is a bronchospasm, the other is an accumulation of fluid and mucus. Albuterol does nothing for fluid and mucus. It affects bronchospasm, which this is not. The fascinating part about this is that even though oxygen struggles to get through fluid and mucus, CO2 gets out without much issue. It diffuses much easier than oxygen does. What that means for us is that I can see it on end-tidal. Why would bronchoconstriction, of course, remember this is a bit inverted. This is me blowing out. Why would this expiratory phase take longer and be harder with bronchos?
They're taking in more CO2 than they're letting out.
No, it's not that they're taking in more.
With like COPD, they do the pursed lips, harder.
You're very close. I guess probably. Mostly what I'm trying to get at here is when I have bronchospasm, I have a physical restriction. Less CO2 is getting out because I physically restricted the airway. It takes more effort using auto PEEP and blowing out over a longer time to force that ventilation past my bronchospasm. Hence, it's represented as shark fin. But even though both of these are wheezing, this is not a physical restriction of the airway. It's just fluid, and CO2 is moving freely through the fluid. It will not show bronchoconstriction. It will not show shark fin. So it's entirely possible I auscultate lung sounds, hear wheezing and pulmonary edema, and think, wait, before we give albuterol, I'm going to put them on end-tidal, because if it's bronchoconstriction, it'll look like that. If it's just fluid getting in the way, well, CO2 will transfer and diffuse through that, no issue, and it'll look different. We'll talk more about that during the airway lecture. I just think that's the coolest. It's like one of the most astounding and powerful things. I wish that we taught it in EMT. I'm irritated that we don't have the time for it. Why would giving somebody Atrovent cause dry mouth? Show me a hand. Why would giving somebody Atrovent cause dry mouth? We're just going to sit here until you figure it out. Oh, wow, at the same time? Henry? Anticholinergic, my man. Well done, all around, Papa. Specifically, aspirin is an antiplatelet aggregate, right? Through the stage of processing here, essentially, if you get injured, it's going to cause vasoconstriction to reduce the surface area. It's going to send platelets to that area, and the fibrin strands are going to cast like a net over it to build up a scab and scar and all that kind of stuff. And aspirin prevents these platelets from getting all bound up. It doesn't thin your blood. It doesn't do anything with the red blood cells specifically. It just prevents that clot from getting bigger. And it's associated with how much reduction in mortality in an AMI? 23-ish. Miracle drug. To the point where somebody's like, yeah, I'm having a little bit of chest pain. I'm like, cool, any chance you could be bleeding in any way? Like, I don't know, bruising, falls, or a cartwheel that didn't work out like you thought it should? No, I will push aspirin through your through your teeth, right? Does it?
That's what King DJT said like a week ago.
King DJT? I don't know.
He couldn't even pronounce it.
He's trying to ban that.
Oh, I got in it to it.
He was trying to pronounce it.
Well, that's all right. If they all just listen to us, the world will be fine, right? So if I've got a guy that's taking daily aspirin and the neurologist says, does your patient take a blood thinner? I will respond, no, but he does take aspirin. It's not a blood thinner, but it does affect our clotting factors. Nitrovasodilates. The theory here is that if I give aspirin and it causes your clot not to get bigger, I then want to dilate the vessel that it's near so that way more blood can flow around it. The issue is, in that all the years that we've been giving aspirin and nitro for AMI, aspirin has a major reduction in mortality, nitro does not. 0%. Zero. Now, maybe there's not enough studies, maybe not enough time, but I do think we should see it on the record soon. I asked a doctor once why we continue to give it, and she said, because it's still good theory. Okay. In the meantime, it's not to be given like an analgesic, but it does reduce chest pain. And turns out when you're not experiencing as much pain, you are reducing your myocardial oxygen demand because you're not stressed and hurting, so send it. But again, there will be times where you'll be on the fence about nitro. You'll be like, his blood pressure is 102 and it was just 110. I'm like, it doesn't meet criteria, but what should I do? I'm like, then don't give it. If you're on the fence about nitro, don't give it. If it's clearly contraindicated, definitely don't give it. But if you're on the fence, don't worry about it. It's not worth it. Which means I give a lot of aspirin and I give some nitro. Now we have to move into a discussion about nitro. It's not just for chest pain anymore, boys. It's also for pulmonary edema. Now I walk up, my guy's got chest pain, he's got congestive heart failure, pink frothy sputum, he's sitting in the tripod position. Basically how this goes is, I check his blood pressure and his vital signs. If it's safe because of the blood pressure, I'm going to give him a spray of nitro and then put a CPAP on him and not take it off again. Then I'm going to put nitro paste on a piece of paper and then place that on his chest. So now we're giving transdermal nitro, and we gave a spray of sublingual nitro. That's the process. Yeah, baby. Heck, the sublingual nitro is more effective than the transdermal by a mile. The problem is that if that CPAP is holding back the fluid getting into his lungs, if I take it off, it's going to come rushing in like a dam broken. So as much as I would rather give sublingual over and over and over, what I'm not doing is lifting a CPAP each time to do it. So I walk up and I'm like, she's tripoding. I say, you got a history of heart failure? No, I don't. Well, she's cyanotic, pink frothy sputum, I bilateral rails. I'm like, okay, hey, go ahead and have you a seat. We're going to check your blood pressure here. Oh, blood pressure's okay. She's not altered level of consciousness. Look, you take any ED drugs? No? Okay, spray, right? CPAP, transdermal nitro. Also, people are prescribed this on a daily, as a daily medication. Sometimes they'll be dizzy and hypotensive and have a nitro patch, 6 or 7 on them because they didn't realize they were supposed to take them off each time. And that's all it is. It's this tiny little tube. You just smear an inch of it. The dose is an inch of nitro paste. Okay. You smash it on their chest.
I was going to ask about that for the quiz. Like when I did the practice quiz, it said transdermal like that, but I guess that makes sense because in regular.
Yep. And also, one of the things that is cool about transdermal is if I put it on them, unlike the nitro spray and sublingual that I can't take back, if they start getting dizzy, you just pull the patch and wipe the nitro off of them and it'll stop affecting them. Basically, your chest pain treatment needs to work this algorithm. I want aspirin as soon as I know I can, never at the cost of ABCs. AB still important. And an early 12 lead. I have to ask Mr. Dennert what he's teaching as far as timing, but oh well, unless you remember. You guys, do you know when 12 lead timing?
As a medic, you do it literally in your vitals.
I would say,
you have someone doing everything else.
yeah, here's my message until further notice. I think it's after ABCs is when you do your first 12 lead. Clear? So if you've gone through ABCs and you think it might be a heart attack, get a 12 lead going. Now, I'm not opposed to you going, hey, my partner's going to get him set up on a full set of vitals and throw a 12 lead on him. Even better. I love it. But never at the cost of ABCs. Okay, what's my airway? What's my breathing? What's my circulation? Fantastic. I'm going to go ahead and have my partner put a 12 lead on. Lovely. Love it. Of course, doing a 12 lead does... Definitely. The 12 lead will not help him, but the aspirin can save his life. The 12 lead is important, but not doing it, transmitting it. A 12 lead that no cardiologist looks at does this man no good. And the major thing that we're doing by transmission of a 12 lead is getting the cardiologist ready and out of bed if he is. Because minutes is muscle. And so if I don't transmit a 12 lead and it turns out that guy's busy on break or sleeping in the house across the street, 'cause sometimes they live close, or he's with a less pertinent patient, that's a problem. So transmitting the 12 lead that might have proof of a heart attack is pivotal in making sure that definitive care is there, but we don't let it get in the way of the aspirin either. So how this goes is I show up, hey sir, you hurting at all? Yeah, my chest hurts so bad. You ever had that happen before? Well, once I had a heart attack. Does it feel like that? I don't know, maybe. Okay. Any falls, planes, trains, automobiles, nothing like that? Okay, well look, are you allergic to aspirin? Any chance you could be bleeding? I'm gonna go ahead and give you some of this while we figure out what we got. My partner's gonna get a full set of vitals as well as a 12 lead right on scene and as soon as possible. Then once I get loaded up in the truck, making sure that I go to a PCI where they can pluck that out of him, we're going to transmit to the place we're going so they can look at it and see it coming. It is not in our scope, even though we start to learn more about cardiology, it is not in your scope to interpret monitors or 12 leads.
So, if it's not, why?
EMTs do it too. Realistically, nothing has changed from EMT class in regards to 12 leads. It's just that now I mean it.
No, question. As a medic, you still transmit the...
Definitely.
Yeah, okay.
Like I said, nitro if it's safe. I got to know a full set of vitals in most cases, or at least many vitals, to give nitro in the first place, which means I might not even be giving it on scene. If my guy looks sick as hell, and I'm like, whoa, let's get some aspirin and get on the way, I'll get a 12 lead while he's sitting there. These are like non-negotiable things. Aspirin and 12 lead while he's sitting there, death's door or not. Then you get him loaded up, get on the way to the place you got to go, transmit it while you're in the truck, give nitro if it's safe. I'm only giving oxygen now that I think it's a heart attack if his SpO2 drops below 90, basically. With me? Better be. Make sure you're using filtered needles for IM, not IM, but just drawing up from ampules with epi. I teach anaphylaxis like this. You will hear everywhere that it is 2 or more body systems or hypotension. I teach anything other than isolated urticaria. If you think that this guy might be having an allergic reaction and he has any abnormal presentation other than not Benadryl, other than swelling, wheals, epi, give epi. What I don't need you on is the fence of being like, well, 110 would be cardiac. He's itching, let's call that pruritus and dermatological. Okay, no, do not be on the fence about epi. If it's anything other than isolated urticaria. In this case, without us having access to Benadryl, I might even give it then 2. But I think that too many people get too squeamish on trying to identify this and waffle the line for epi. Sebastian?
So registry wise though, is it 2 or more body systems?
I'm very, very confident you going to registry like how I taught you exactly. If you walk, because here's what happens. I do think they're specific about 2 or more body systems. I think 9 times out of the 10, students miss it. They'll be like, your guy coughed once while transporting and presents with this other symptom. And that cough is a sign that his respiratory drive is affected, which you blow right by it. Or they'll say, well, he's got itching in his skin. And they're like, okay, well, that's just one condition. It's not. It's involving his nerves and his integumentary system. It is 2 systems. It's just one complaint. And so I'm like, okay, I have learned that if it's anything other than that, we'll call it anaphylaxis. And I'm sure that'll be fine. Also, it's not hard to make. If you got 1 to 1,000, you just need to draw up 1 milliliter of it and mix it in a flush to make 1 to 10.
I don't know why I thought it was a different thing.
If I have 1 milligram and 1 milliliter and I suddenly need a 10 times diluted, then I need 10 milliliters and 1 milligram. That's all. Your algorithm for EMT was basically check a pulse, do CPR, and put them on an AED. You do that while you call ALS or med control to get orders. The only things that's changed really is the fact that you are ALS now, which means my message has gone from, hey, call a big doctor and ask them what they want to do, to do not transport cardiac arrests. You work them on scene and then call them right there. Bring a shovel, you can bury them too. So we don't transport cardiac arrest in AEMT. The only thing that's changing on top of that is that we're doing epi as soon as we can, but never to interrupt compressions or AED use. I start doing compressions, AED arrives, he puts it on, I'm doing compressions. I say, hey, why don't you go ahead and start a line while I'm doing compressions, we can throw in some epi as soon as you can. And then if you do that, essentially we're just giving epi every 4 minutes, and that AED will assess every 2 minutes, which means every second time the AED checks, you give epi. Alanis? I'm gonna eat up some time here.
With cardiac arrest.
Eat up some of your lunch.
When you want to transport. When you
No, we don't.
Never? Even if you get a pulse?
No, they live there now. I saved his life. Welcome back to your own home. You definitely transport if you get ROSC. But one thing, we'll talk more about it in cardiology, but mostly I would say this. What happens is people get ROSC and they think, oh, sweet Jesus, now we can get out of here, and they rush. When you get ROSC, you slow down. This person just came back from the grips of the Grim Reaper. Be easy. Don't go jostling them around. Take it down a notch. We tiptoe, and it takes, I have to work so hard against a pile full of first responders on scene. They're all like, we got a heartbeat, let's go. And I'm like, everyone, hey, on me. We slow down now. Let's not lose this fanned flame we got, because whatever killed him, I didn't fix. I just brute forced his heart back to work with my hands and a chemical. But whatever killed him, nothing has changed. So let's be easy.
I'm asking because with us, if you have some stuff going on, you can transport. You have to like think about all stuff. If it's a witness arrest, it's like, okay, maybe we can transport. If you have a good and title, it's like, okay, maybe.
You're in luck. I require much less thought.
Okay, cool.
The idea is this. There are 2 things. Actually, go ahead, because I don't want to get too far away.
I was just going to ask about, like, would we give cardiac epi post-shock if it shocks? Or, like, how does that?
The shock is irrelevant.
It doesn't matter?
Yep.
Okay.
In VFib, VTAC, asystole, PEA, and all cardiac arrest rhythms, each one of those gets epi. So we're giving epi every 4 minutes regardless. Even the flat line. So there are 2 things proven to improve outcomes in cardiac arrest. The first is uninterrupted compressions. What's the second? Early defib. Wait, you said epi? Of course you didn't, because the only 2 things proven to improve outcomes in cardiac arrest do not include epi. The surefire way to interrupt compressions is to start transporting. There is nothing in the first 10 minutes, essentially, of a cardiac arrest that a doctor's going to do that a paramedic can't. which means interrupting those compressions is the most catastrophic thing you can do. Now, it does mean you need to call for a paramedic because you don't have bicarb and you don't have calcium and magnesium sulfate. Admittedly, sure, but call for a medic and don't transport. Now that we got epi, I'm like, absolutely not. Work it on scene.
So if we're not transport and the patient will go back, die, you call for med.
For cessation?
Yeah.
To give you a short answer on that, I would say work an arrest for 30 minutes and then call a doctor to cease. Later when we talk about end tidal, I'll say if he dropped below 10 for 20 minutes, don't even need to call a doctor.
Is that?
Yeah. It's like looking at a person without a head. I'm like, you better call a doctor and see if this decapitation, I need to work it. I'm like, what? Absolutely not.
So you will work for 30 minutes before calling?
Yeah, we'll say that for now.
All right.
The big emphasis here is don't transport cardiac arrest. One of the confusions that's coming since about the sugar issue is that it is still our priority to give oral glucose. Yes, it is an enteral route, but because it's not a molecule that needs to be like broken down and changed by the liver, it's lightning fast still. It'll still go through into the GI tract and through the portal vein, but it works very quickly. So your priority should be least invasive to most invasive. You start as an EMT skill, and then you move on if you must, which means we are very excited to give oral glucose to our patients. Now, the only reason I'm not doing that is if they are a choking concern, in which case now we're secretly super happy we can start a line and run dextrose. But the only reason we're giving dextrose is if glucagon is if IV dextrose isn't available, either because I don't have any or I couldn't get an IV. So we're not leading with glucagon, we're just doing it if we can't give oral glucose in D10. In fact, I think that's probably listed as a contraindication. Nope. It's just part of the indication. Oh, and this one, if you'll remember correctly, essentially, Rose had brought up in class, she said, well, why do you have it listed as pregnancy as a contraindication? My sister is getting it. Did you look into it?
It's a small chance, but it's still unstudied. It's a grade B drug.
I looked into it too. You were right, I was wrong. F. Which I always say the same thing. Look, I hate being wrong. What I hate a lot is being publicly wrong. What I hate most of all is staying wrong. And if I got to sacrifice myself on the altar of humility, then so be it. So I looked into it. And if I'm being honest, I went in like, well, I'm going to teach this young lady a thing or two about some Zofran, blah, blah, blah. And I was like, oh, snap, my bad. Now, I'm not all the way wrong. The FDA has never approved Zofran for use in pregnancy, so we don't actually know. Around 2010, essentially, a study or two came out that said cleft palates and cardiac defects. We have since done a bunch of studies, none of which have proven that to be the case, which is why, just like you said, my dear, that it's largely now, mostly it was, I realized the reason why in my career it's been like, yeah, and no, it's when the medical directors switch. Because some medical directors were like, the FDA doesn't approve it, we're not doing it. And the other ones are like, yeah, but it's not causing an issue, and that's why it's swapped for me. So I appreciate you bringing that up. It was fun research, and you were more right than I was. Is Zofran a life-saving intervention? No?
Oh, okay.
If this guy starts complaining of nausea, I have basically one of two options. Take him off the board, be very careful, that's 3, or give him Zofran, right?
You don't have to take it off the board, you can literally lift.
If it's a light, well, sure, we can tilt it to the side.
Yeah. Unless you're on the ambulance, I guess.
What is this sign called?
Gray Turners.
Gray Turners, turn to the side, Gray Turners, which indicates what?
Retroperitoneal bleeding.
Whew, anybody else getting hot in here? Retroperitoneal hemorrhaging. It means bleeding on the inside and specifically outside of the peritoneum. If she has bleeding, her kidney is bleeding, and she retches, how much pressure does that push? What's the exact number? Who knows? Yeah, it's got a bar in it. Anyways, my point is I think sometimes people are like, Zofran, blah, blah, blah. I'm like, yeah, but aspiration risks, it's great to be administered. This person has an internal hemorrhage. If she develops pressure because she's throwing up, that's a problem. And so I might even give her Zofran if I suspect she becomes nauseated or is going to vomit because I don't want her to move her insides around anymore. She's hemorrhaging. We are not going to talk a whole lot about long QT syndrome. Zofran, you and Landon will get along really well. Zofran is, here's what I need from you as a AEMT. We're not interpreting the rhythm. We understand cardiology now as a concept. If I say VTAC, you have to know what it is. Sorry, people at home on the mic. You have to know what it is. As an EMT, you didn't. As an AEMT, you have to know what VTAC is. I don't super care that you know what it looks like. Now, before I give Zofran, this is what I'm doing. Do you have any history of dysrhythmias? If they say yes, I'm now cautious about Zofran because it might be prolonged QT syndrome. I'll ask them, are you on any beta blockers? If they are, well then I might consider withholding Zofran. Why? Because they contribute to long QT syndrome. If he has a pacemaker or AICD, the summary of this is if I'm treating nausea and it's not a life-saving intervention and you got a history of dysrhythmia, I am not giving it to you. If I talk to a patient, like, I'm talking to Kendall, I say, oh, I just feel so nauseated. I'm like, okay, well, why? I don't know, I've had a headache all day. I'm like, look, I got Zofran, it's gonna cure your ailment. You ever had any issues with your heart? She says, no. Awesome, send it. If she says, yeah, something weird about my heart, I'm like, what kind of weird? She's like, I don't know, like dysrhythmias of some kind? She's like, yeah. I'm like, sorry, baby, we're gonna hold off on the Zofran, because it might be a very specific situation. So in summary, what I need is for you to just ask, do you have a history of heart dysrhythmias? And if they don't, then I don't care. Lastly, Cyno kit. You see this bottle here? That is your delivery. The Cyno kit essentially is this giant bottle of red sludge that you turn upside down, stick a drop set in, and then drain it into the patient. That's what a Cyno kit is. Cyanide smells like almonds, and it prevents the binding of oxygen. Like I said before, if you wanted to do it over time, it's pretty simple. You take the bottle times the drip set, which will always be 10 or 15, it's also macro. Always be 10 or 15 macro set, and you multiply it by the time in minutes, and in Cyno kit's case, it's 15 minutes. But again, it comes down to 30 seconds, which I had a beat per minute there, but I don't want to factor in that time. But it's fast, right? Now we're talking 3 drops per second. Triplets if you nasty. Yeah.
I have a question. Is like the smell of almonds, like, are you gonna like walk in somewhere and it's gonna think about it immediately, like or is it like really faint?
Didn't somebody on registry get a almond question? If I wasn't sure that was gonna happen, I wouldn't say the word. I'm pretty sure if you smell cyanide, you are up a creek. You are in big trouble. You're gonna get it, yeah, big time. However, I want you to suspect it long before you smell it. You know much about cyanide stuff? Basically, burning plastics. If I'm in an industrial situation or if there's a house fire with burning plastics, that's where cyanide is usually, we're getting exposed to it. So if you smell almonds, you should run. Chances are if you smell almonds, we're gonna be talking about you over a shallow grave eventually. So, but again, in a similar situation, 250 milliliters at a 10 drop set is 3 a second. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2. You know what I mean? I can't not do the triplet. But the point is it's fast. I'm okay with you timing these bags. Okay, in 5 minutes, how's it going? In 10 minutes, how's it going? Open it up more, close it down. It's super red. I'll do this because I want to get through some choice information. If you have questions, we'll kind of ask me on break, but I just want to get through a couple of things that even if you're looking at the slideshow, you're like, oh no, I wish I would have pulled that away. Cyno is super red. That is more red than carbon monoxide will make you. Cyno kits make everything red. It's the only thing that I know of that should be in an independent line in the AEMT scope because it will calcify with other things. So a cyano kit needs to be in its own independent line. It comes, see his urine right there? It makes everything red. It's super red in the bottle, super red in the line. It turns you red for a week or so and it makes your pee red, all kinds of stuff. Basically what's happening is cyanide gets into your body, and I don't need you to dig too hard into these perfusion discussions right here, but you all know that if you stop breathing, you die. Partly because you're not getting in oxygen, but also because you're not getting out what? CO2. You also know that you can die from hypoxia even if you're breathing fine. Why? Because I'm breathing in oxygen, I'm breathing out CO2, but I'm leaking too much blood. So there's not enough hemoglobin getting to my lungs. Even though I'm breathing fine, I'm not dying from a ventilation problem, I'm dying from a perfusion problem. Carbon monoxide, right? Like we would smell from a car or breathe in from a car or some other fossil fuel. If I'm sitting in a garage, a closed garage, and I'm running the exhaust, am I having a ventilation or perfusion issue? Neither. I'm having an issue with the blood itself. I'm getting enough oxygen, I'm offloading CO2, but it's not attaching to hemoglobin. It's a completely different animal. And that's where cyanide falls in. The point I'm making is that you can look at a person that just got pulled out of a house fire, he's pink, warm, and dry, talking about difficulty breathing, but the issue is his oxygen is not being allowed to get into his mitochondria. And so that's what cyanide is doing. And so the cyanokit turns it into B12. It just makes it largely an innocuous, and you end up peeing it out. Lastly, make sure you emphasize the summary of these things. Saline is good for volume replacement and heat emergencies, but of course, be careful in trauma. We need to consider the trauma triangle and permissive hypotension, both systolic and MAP. Lactated ringers is similar to saline, except for it includes a buffer, lactate, or what can become a buffer, and a whole bunch more of electrolytes. Now that's a problem because if your liver isn't able to turn the lactate into the buffer, you'll have too much of it and it actually puts you in acidosis. But primarily, my major issue with lactated ringers is that it includes potassium. And potassium can be a major contributor to dysrhythmias, which means if you have end-stage renal issues or an acute kidney injury and you can't process it, lactated ringers, potassium builds up in your system and I put you in VFib. So generally speaking, we're running normal saline, unless major fluid loss, and usually not in the field. But it's not crazy. You want to run a scenario, and you get a guy, and you're like, whoa, the guy's MAP is 62, he cut himself wide open. I'm going to choose lactated ringers and administer it according to permissive hypotension. I think that's a great idea. He's probably acidotic. He's got major fluid volume loss. We just have to watch him. Good enough for me. 1300, see you in lab, skill lab.